हाँ जी, हाँ जी।
You don't have to introduce because as I speak, I will introduce. I mean, I introduce them in the recording itself. So you don't have to introduce the speakers. Are we going to start or waiting?
So we can start. Technical team, kindly display.
And don't introduce because I'll introduce them as we go along in the recording itself. So don't worry.
Okay,
Display.
so we'll just introduce you, sir. We'll just introduce you. Dr. Utkarsh. Dr. Utkarsh, can we start the session, please?
Hello, am I audible?
It's a little louder.
Yeah.
Hello. Dr. Ayushi this side. Am I audible?
Yes, you are. Just a little louder. That's all.
Okay, should we start with the session?
Yeah, you start. Huh?
Is the voice better now?
Disturbance.
I can't hear anything. आवाज ही नहीं है. इसमें आवाज नहीं है. Good afternoon, everyone. I welcome you all to the World Conference on COVID and Critical Care.
We'd like to begin with the first session for the day. It is a panel session, and the topic for this session is preventing volume or barotrauma in COVID ICU. The session will be moderated by Dr. Ashit Hegde, consultant in medicine and critical care, PT Hinduja Hospital, Mumbai. I now hand over to you, sir.
I think I'll introduce the panelists as we go along. So I request you to place as we go along, we'll introduce each of the panelists as we ask them questions. So please play the recording and start the session. Thank you.
Technical team, please play the recording.
Good evening, everyone. I think all of us who have been dealing with COVID patients would agree that we are seeing much more evidence of barotrauma in these patients as compared to the usual patients with ARDS. I think all the panelists will agree. If anybody who wishes to disagree with this, you can speak now. Otherwise, we go ahead. Now, what are the reasons for this? What we can do to prevent this is essentially what this topic is all about. So I really won't waste too much time because we have many issues to discuss and we don't have enough time. So I begin straight away with my first question. The first question is addressed first to Dr. Rajesh Chawla, who's a senior consultant in respiratory and critical care at the Indraprastha Apollo. So Rajesh, the question really is that, do you think this increased incidence of barotrauma is because the lungs are intrinsically more friable? Or do you think it is because so many non-intensivists are looking after COVID patients and they probably didn't manage ventilation properly and therefore there was more barotrauma? What are your views? And then I'll ask Sharmili for her opinion.
You know, there is no doubt we all saw a lot of barotrauma with this. And there are a lot of pictures which people have seen a lot of pneumomediastinum going on to subcutaneous emphysema, and a lot of people have seen. You see, the lungs are frail. They have intrinsically, they are more prone to develop pneumomediastinum, pneumothorax in these patients. They progress very fast. A lot of people have said that if you see the little bit of air around the vessels, in the vascular, perivascular, you find that is the initial thing. And then these patients are more prone to develop. And we have seen barotrauma not only with the invasive ventilation, and we've seen with non-invasive ventilation. You'll be surprised, we've seen even with HFNSE. Of course, the incidence is not as that much we see with the invasive ventilation. So we have all seen. Exact reason, absolutely not clear, but there is definitely a lot of theories have been sent, and people have seen even the cysts, which are more prevalent in these patients. And barotrauma, when it occurs, of course, it increases the length of stay. People stay in hospital longer, and the mortality all across is very high. In these patients, people who develop barotrauma, the mortality was above 50% or even touching 60% in certain. And people who did not develop, the mortality was around 48, 49%. So definitely these patients are more prone to develop. And I don't think it is the reason that the non-intensivists were managing, even with the low tidal volume strategies, even with the plateau pressure below 30, we all have seen people, certain individuals developing more of barotrauma. So it is not that the non-intensivists were managing. Of course, if you are not giving the low tidal volume or lung protective strategy, probably the incidence would be much more. But even after managing with the low tidal volume lung protective, by the best intensivists, all of us have seen more barotrauma.
Thank you, Rajesh. So Sharmili, your views, do you agree with what Dr. Rajesh says? Sharmili Sinha is a senior consultant in critical care at the Apollo Hospital, Bhubaneswar. So Sharmili, what are your views? Do you think this was inevitable, or you think we could have managed these people and prevented some barotrauma at least?
Yeah, I partly agree with Dr. Chawla on this actually. The first point I agree definitely that the lungs are more frail or fragile, I can say, and they are definitely stiffer than the non-COVID ARDS cases that we have been treating for decades together. And given the different kinds of phenotypes that have been described in literature in the last 1.5 years, we have seen all permutations and combinations. But that apart, I would say both during invasive and non-invasive ventilation, the incidences were high. How much of this was consequential, that remains to be seen and analyzed. And I would say that most of the times these patients due to infrastructure limitations or logistic reasons, they were put on non-invasive ventilation or HFNC for longer period of time, which led to more the tachypnea and more generation of negative pressures, which probably led to this kind of ventilator-induced lung injury. And the second point also has a definitely role to play. I would say I would not say it's non-intensivist, but even the experienced and intensivist also did not get much time to spend with these patients directly because of this again limitations that compared to non-COVID ARDS cases where you used to spend more time by the patient's bedside. Obviously, the senior consultants were not by the bedside. It was definitely left to more of the junior doctors and the paramedics who were handling the ventilation. I think definitely that part also has a role to play. So combined, these two factors have a role to play in higher incidences of this pneumothorax and pneumomediastinum.
Thank you, Sharmili. So would any of the other panelists like to say anything, or then we'll move on to our next? If there's anything, please raise your hand. Otherwise, we'll move to the next question. Welcome back, Dr. Phua. And Dr. Phua Jason Phua is a senior consultant and CEO at the Alexandra Hospital in Singapore. So the next question is to you, Dr. Phua. After that, I also asked Dr. Arvind Dahia for his opinion. So this concept of patient self-induced lung injury was there almost 7 years ago, but it didn't become very popular. But after COVID, this has become very popular. But still, many people debate this concept. They really think that this thing is not really true. So what are your views? Do you agree with this concept of patient self-induced lung injury, or do you think this is doesn't really contribute much to the progression of ARDS in these patients?
Hey, thanks. I think it is wise to agree that at least there's a good chance that this is a real thing, patient self-inflicted lung injury. It was made popular by Lauren Brochard, as you say, a few years ago, but the evidence actually came way back pre-World War II, and I think there was a landmark study about 30 years ago by a chap called Mascheroni, in which sheep were instilled agents to increase hyperventilation, and then thereafter suffer a fair degree of lung injury. And since then, I think a lot of the work has been by Takeshi Yoshida as well as Marcelo Amoto. Again, experimental data, and some of the work in humans were also based on case reports as well as observations that if you give neuromuscular blockade to prevent patient spontaneous breathing, there's less lung injury. So I would say that the data are not 100% strong, but there are indications that if a person breathes and has huge respiratory efforts, you can cause large tidal volumes as well. And as a result, volume trauma. If a patient breathes very hard, you can cause quite a bit of transpulmonary pressure. As such, you can cause barotrauma. And if you don't have enough PEEP and there's all kinds of athalec trauma, you can cause lung injury as well. If you suck too hard, you can cause transvascular shifts as well, and you can cause pendulum. So all of the above are at least physiological reasons, and coupled with some of the other data, I think that there's a good chance that PCLI is real, and I think as a result, we have to watch out for it.
Thank you, Dr. Phua. And the next, the same question, Dr. Arvind Dahia from Rohtak, intensivist and consultant at Rohtak. What are your views? Do you agree, or do you have any differing views about this whole concept?
So, Naresh, I kind of more or less agree with Jason that patient-induced self-induced lung injuries has a significant sound physiological basis at least. If we can think that way, that patient, not in every patient we can prove it, like having an esophageal pressure monitoring for every patient, but we realize that patient who are kept breathing too hard in a way that too much of a negative swing and high tidal volume, those patients, if not addressed early, they ended more into the intubation failure, non-invasive failure. Those who were put early support, they responded better. So in that sense, we can relate. I'm not saying that the strong evidence has been emerged, but the evidence is now coming forward. And as Jason mentioned, when we are hyperventilating as a response to dyspnea, we aerate more that lung which is already aerated, and the negative pressure around damage more lung and create the more floating alveoli and negative pressure and pulmonary edema. All these things might contribute. And during COVID, we have seen that patient left longer had more ventilation than we intervened early. So it does have a sound basis, I believe.
So that means both of you tend to think that probably spontaneous breathing is not as, safe as you would like to think. And both of you would agree probably that we need to intubate early. Both of you agree with that? Or in case the patient is not doing well on... Is anybody else on the panel having any different views? Or
Sorry, can I just say that even though I tend to think that PCL is a real thing, I do not think that it means that we have to intubate early. I think that we have to look at...
What I meant is, obviously you won't intubate early, but you sort of don't... In India, a lot of patients were being intubated, we were continuing NIV. So maybe your threshold, what about the threshold for intubation? Would it be higher or lower than the usual patients in COVID patients?
Personally, I do not think that there's a difference between COVID and non-COVID in terms of threshold, but I would intubate based on how the patient looks. If the respiratory drive is huge, he's tachypneic, he's got huge tidal volumes, yes, I would intubate.
No. So the thing is that in a lot of patients in India, or maybe all over the world, because of resources or whatever else, the threshold for intubation was a little higher than it was for the usual. So whether this is a good thing or bad thing is what we are going to discuss. But you would probably intubate at the same level as you did before. You wouldn't have a higher or a lower threshold. That's what you say.
Yes.
Thank you. Anybody else would like to say this differ? Or Arvind?
Yeah, same way. If we see that we didn't treat COVID patient any different than the non-COVID ARDS. We went by the physiological parameters. They are deranged. We need to intubate as we do. I would rather use the term don't delay intubation. You want to try an IV? Yes, by all means, try it, but don't delay. And so many times we didn't even wait. We just went ahead with the ventilation straight away. The patient came to our facility.
Yeah, we'll discuss this in more detail.
Physiological response.
Thank you, Arvind. Anybody else want to say any point? Or we'll discuss this in the next couple of questions anyway. So as Dr. Rajesh Chawla told, Dr. Kedar is a senior consultant at the Wokat Hospital in Bombay. And he said that he has not seen too much of barotrauma in patients, although he has seen a few, has not seen too much of barotrauma in patients on HFNO. So what are your views? Have you seen, and if you have seen, how do you think you can prevent barotrauma in patients on HFNO? Or you think it's inevitable?
Yeah, I agree that I have not seen many patients with barotrauma on HFNO as compared to obviously invasive ventilation and NIV. And we must have seen a couple, okay, not more than that. And probably in them also, probably they must be having some amount of barotrauma, pneumomediastinum, which is not picked up on the routine imaging because CTs were not done for all the patients. So if you get barotrauma with HFNO, so how can you reduce that? So obviously HFNC works not only because of the humidification and the high flows, but it gives you some amount of PEEP. So the flows can be reduced. So the flows, roughly the calculation is that for around 10 liters, you get a PEEP of 0.7, okay, for each 10 liters. And in patients whose mouth is closed and who are breathing exclusively through the nose, and in those patients who are breathing through the mouth, it's around half of that. So maybe you can reduce the flows here. If the patient is comfortable, come down to the minimum flows. That helps to prevent the aerosolization, which was initially thought to disseminate the virus also. So that's one thing to do. And obviously intubate whenever the work of breathing is high on, or as everybody said previously, follow the physiological principles, follow our conventional rules for non-COVID ARDS also. So don't waste much time in intubating these patients if they are going worse. So I still don't believe HFNO is a major cause. You have anecdotal case reports also pre-COVID era of barotrauma with it, but it has the least incidence as compared to the other forms of ventilation.
No, the problem, Kedar, with reducing the flow, sometimes these patients have high respiratory drive. So you reduce the flow, their own, their own effort increases. So
yeah. So what we used to do is we sat them on a small dose of dexmedetomidine or awake sedation, and that really helped us to tide off that anxiety and extra effort which they had.
Sedation later. Thanks.
Yeah.
So Sauren, what are your views? Dr. Sauren is from the Rabindranath Tagore Institute. Is a senior consultant head of department at Rabindranath Tagore Institute in Kolkata. So Dr. Sauren, what are your views on this?
I think it is very difficult to actually speculate that because of the thing that some of the patients, there is an overlap. Overlap is like that, some of the patients they are on HFNO. So then that patient is again going to the sometimes non-invasive ventilation. So really very difficult. But in some patient, we have basically faced that patient of on HFNO, they develop that pneumothorax or pneumomediastinum. So particularly those patients, what I am speculating very deep, in spite of the difficulties in whether the NIV or HFNO, because of that overlap that caused that pneumomediastinum or that barotrauma, but still the feeling is that, or my feeling of my unit is that once the patient is very much tachypneic, they are having a very high flow of the HFNO. So that time there is a possibility that has caused that HFNO. And sometimes actually immediately it is also difficult to pick up immediately the cause of pneumomediastinum or pneumothorax. So the detection may be little late. So that's why temporarily it is very difficult to detect also. But according to our experience, I feel that maybe marginal increase in chance of the pneumomediastinum or barotrauma in patients with HFNO. And obviously, as I discussed with that time we can take precaution that the flow can be little bit actually modified, particularly those patients who are not mouth breather. Where the patient is breathing through mouth, that time sometimes this effect may not be there, but that once the patient is with the closing mouth, they are breathing very fast and flow is also high, that time there is a possibility that it may cause little higher incidence of the barotrauma in whatever form is there. So that's what I feel.
Thank you both, and I think so. Both of you tend to agree that the incidence of barotrauma is probably lower in HFNO, and if the patient, you could try reducing flows, and obviously it might require some judicious sedation, which we'll discuss as we go along. Would anybody else like to make any points about HFNO before we move along? So no other views from the house. So we go ahead with the next, up to the most important question, the million-dollar question. Though I agree, most Western literature says that in patients with COVID, non-hypercapnic patients with COVID who fail HFNC should be intubated. But I know the reality in our country really has been either because of lack of HFNC or whatever, lack of resources. Patients who failed oxygen and oxygen not available, a lot of them were on NIV, and there have been several patients who on NIV for a long time did recover and go home. So it's though they would otherwise, in other circumstances, have conventionally been intubated and ventilated. So that's what I wanted to ask Dr. Neeru Gaur, who's a senior consultant at Jodhpur in intensive care and anesthesia. So what are your views about this, Dr. Gaur? Do you think for COVID is it different from the usual ARDS, or do you think we should behave like the usual ARDS?
No, sir. It is very hard to differentiate which patient needs to go on NIV, which patients need early intubation. It's very hard. So we have to clinically assess, and I have seen in many patients that the patient with a CT severity score of 21, 22, 23, 24, 25, and they are doing sometimes good on NIV, while there's another patient with the CT severity score of 11, 12, they get worse on NIV. So, sir, it is very hard to case where to put the NIV and which patient will be benefited. This is the thing.
How do you decide then? What do you do?
Just the clinical deterioration, and we have to see that self-inflicted lung injury should be reduced and the patient anxiety should be controlled. And by controlling these two measures only, and we have managed many patients. But the incidences of pneumothorax has been seen even in HFNC and even in high flow nasal cannula and in high flow mask also. So it is very hard to differentiate. Just the clinical deterioration we have to see, and accordingly we have managed. So.
Thank you, Dr. Arvind. What are your views on NIV in COVID?
I mean, we used NIV a lot. I mean, that is it was helpful. Let me put it that way. It was not unhelpful. We saved a lot of patients by using NIV. When I add that, I must also reiterate that we didn't see anything different, which is not a COVID versus non-COVID. We went by the basic physiological parameters. Suppose patient is exhausted, there's no point in waiting. We straight went for the intubation. At the same time, when we are seeing that patient is more like they need, they just come to the facility, they're anxious, and they haven't been supported yet. That's the time, just time to wait and see how the response will be. There's no need for the immediate intubation in these patients, but we can try and then sequentially we can assess and see if they can be helpful. There can be some objective evidence like H-core score, where you can score the heart rate, GCS, respiratory rate, PFA ratio, and then you can make some judgment. There is no hard and fast rule. But if a patient is breathing at more than 40 and with a PFA ratio less than 200, how far you can stretch him? Probably not. So it's a very more of a one-to-one cases rather than having a thumb rule. We went by and leaving someone put an HIV observe for 12 hours. No, that's not how it would work. It has a place, should be used, but should not be carried for a long time. If we are not improving and rather this physiological response is worsening, then we should take over. That's how we practice this.
See, the problem is very easy if the patient is not getting better. I think it's a no-brainer that it needs intubation. The real problem is there are a lot of patients on NIV who continue to do comfortable. They are but on a plateau. They're neither getting better nor getting worse. So, that's the point. Decision. So in such patients, what do? Do you cut your losses and intubate even if they're seeming comfortable, or do you actually wait? Because some people say that just delaying this whole NIV business is prolonging and causing them moving to a more severe ARDS. The whole issue really isn't. See, when they're in distress, I don't think there's a big issue. There's no debate. It's not a big thing. It's the patients who are comfortable on HFN or NIV, which is the issue. That after you intubate them after 10 days, you think maybe I should have intubated him earlier. I mean, that's what I'm saying. How do you decide in such patients that?
May I answer that, or should I answer that?
Beg your pardon?
May I answer that?
Yeah, it's for you. Then I'll ask Dr. Chawla anyway for Nick. Yes, okay.
Yeah. Basically, what we do, suppose if you look at the CT scan and X-ray, H type, and we are dragging along for 1 day, 2 days, we are still to 70%. I wouldn't. I would rather intubate early when there's a high recruitability. Why to carry on? The main, again, we couldn't find a hard fast tool, and many times we also felt we could have intubated this early. Because, for example, we have a patient who came with was doing well in HIV, got a secondary infection. Within a few hours, it changed a lot, and we see that the CT scan repeated. We found the bases were gone. In that case, though he was not doing too bad on an IV, we decided to take over. Again, I would say rather is more of individualizing the care was more important, looking at the recruitability, exhaustion, and these what has caused any sudden further deterioration. These factors played more heavily on our mind rather than having a thumb rule in the situation.
So, Dr. Rajesh, so you wanted to say something, and then of course the next question also to you. So first, what did you want to say about intubation? Yeah, you're in unmute. You have to unmute.
You see, I'll tell you what I have been doing. See, there are 4 conditions when there is no doubt you prefer NIV over HFNAC: COPD, cardiogenic pulmonary edema, OSA, and OHS. There is absolutely no doubt you prefer NIV over HFNAC. All other patients, you should prefer HFNAC as a first modality if it's available because of various reasons. Now, how to go on to invasive ventilation? See, if patient is deteriorating within few hours, this patient will go on ventilator very fast. There you have to be quick in deciding. There are certain patients who will linger on, but if their FiO2 goes beyond 60, 65, and it has been increasing, he's in respiratory distress, is using his accessory muscle, you should intervene rather than just continuing because the SpO2 is maintaining. I found this strategy probably resulted in better outcome because there are n number of papers in hypoxemic respiratory failure in all non-COVID ARDS that if you continue and delay the intubation, it increases mortality. So that is what I have been following. And most of the time, it is always a clinician decision. And he has to have how he's deciding so that when he's not around, the associates, the residents can make a decision accordingly.
So what do you tell them then? How do they decide? So what are the parameters you tell them to decide about?
See, I told you, the one is, suppose a person is getting into respiratory distress, requires...
Those are the easy indications. Really, the problem is the borderline patients who are neither getting better nor getting worse. See, if they're getting worse, it's
if the FiO2 is okay, patient is appearing comfortable, you continue. This was the...
But you would continue indefinitely for 10 days, 15 days. That's the whole...
Time is not a limit. And all of us have saved a lot of patients. If patient is continuing on FiO2 of 0.5, he's not in distress. I have continued for even 15, 20 days and people have come out. It is the clinic, how the patient is appearing and the FiO2 requirement. See,
on the other hand, there are patients who have gone for 10 days, 12 days, then afterwards they quickly go down and then you regret. That's my worry. So is there anything that can be done for these patients? Should you have intubated them early?
There is, you need to observe them, quickly go down. They will give you, if a person develops a secondary infection, he'll go down even on invasive ventilation. So you can't say that because he went down.
So you're saying, from your point of view, prolonging NIV is not necessarily bad if the patient is otherwise
you
well?
need to have a parameters on which you, if the patient is not getting better, how is the trend? That is more important than a static what you are finding.
Fine. Sharmili wanted to say something.
On that particular category of patient where you're pointing out, like those who are happy to be comfortable on NIV for long and how to tube them. Distress is a very clear-cut indication for tubing them. We had actually this kind of cohort of patients a lot. And I would say that after a few months, we decided that some of these patients who are on continuous NIV, but during feed also, for some time also, if you're disconnecting the non-invasive mask, they tend to desaturate first. So if you look at their trends for 2 to 3 days or 4 days, they have been continuously on NIV. And if you speak to the nurses who have been looking after, that they tend to desaturate fast, even if they are given feed during a period of 10 to 15 minutes. I think these are the kind of patients who do not even tolerate few minutes of withdrawal of pressures. They are the ones, and this is a kind of subtle indication that they actually need the institution of invasive ventilations. So later on, actually, we modified our criteria. And some of the patients who did not want to go for, family did not consent for intubation and invasive ventilation, there we had to continue. But I would say 9 out of 10 such patients actually ended up in invasive ventilation late, and they had a worse outcome. So those patients who are on continuous non-invasive ventilations and even do not tolerate 1 or 2 hours of withdrawal, I think they are the kind of patients we should have a low threshold for converting to invasive ventilations. At least alert the family, take the consent that we might deteriorate later, and outcome won't be good.
Thank you. Dr. Fua wanted to say a few words. I think he's raised his hand. So Dr. Fua, what did you want?
Thanks. I just wanted to echo what Dr. Rajesh said, that I think that if a person is comfortable, no matter how long the patient is on HFNO or NIV, he's comfortable, you can still cycle on and off. There's no real indication to intubate. I know that right at the start, the early days of HFNO, the Koreans published a paper that showed that if you delay intubation beyond 48 hours, that could be associated with worse outcomes. But since COVID, and I can quote a systematic review by a investigator called Eleni Papuzzi. This was published in Critical Care earlier this year, which looks at thousands of patients, and there was no association between delays in intubation and adverse outcomes. As such, I think really it is a clinician's judgment. Patient looks comfortable. It's not the timing, it's the comfort of the patient that matters. Thanks.
Sharmili's point about the patient who's very comfortable on NIV, but the moment you disconnect for feeding, what do you do about these patients? Would you put a nasogastric tube otherwise, or you would think that it's time to intubate such patients?
In this case, because it is COVID, I probably have a lower threshold. If I can't even take it off a little bit for feeding, then I'll be more careful, purely because of the danger associated with emergency intubations in COVID.
There is no doubt that if brief period of discontinuation, patient becomes so desaturated, but then when you disconnect, you must give them oxygen. And if a person is above 0.5, these are the patients who will become desaturated. If it is below 0.5, these people will very easily tolerate a face mask or a little high flow of oxygen for that brief period.
Thanks. The next question anyways to you, Rajesh. So while you're the NIV expert in our country, so how would you, in a patient, suppose like many patients, like you said, in our country, because HFNC was not universally available, many of them, though it doesn't fit the classic indication, non-hypercapnic, still were on NIV. So in such patients, the majority, you must agree, were on NIV before they got intubated. So what would you do? What settings, your PEEP or whatever, what would you do to try and limit the progression of barotrauma, or to limit the progression of lung injury in such patients?
Now, like we've been listening about the spontaneous breathing induced lung injury. So, these patients initially have a very high drive, and previously people had differentiated into L type and H type. Slowly people are coming that it is like an ARDS only. It is a process. Initially, if you come across, you have a low type and then they go on to H type. This is a natural course of these diseases. Initially these patients have a lot of respiratory drive and they don't require pressure support. Even just CPAP is enough. Even if you give 2 to 4, they would create 800, 900. So it is very essential that you give sedation. Dexmedetomidine, we have given to a lot of patients, even the low dose of fentanyl to these individuals, because if they breathe at a very high tidal volume, the very fundamental of low tidal volume goes away. Because, in the SAFE study, they found, in the other studies also, they found that NIV patients, when hypoxemic patients were given, they were taking more than 9 ml per kg. So you have to give low pressures. And if a person is taking more than 6-7 ml per kg of ideal body weight with the NIV, then probably I don't give a pressure support. I just give them a CPAP and mildly sedate them if the drive is too much. That is what usually we followed in all our patients. And we found that, of course, many of these patients still deteriorated. Many of these patients still deteriorated within few hours. All of us have seen. But that is the policy which we followed in these patients when we were giving non-invasive ventilation. As I said, I preferred HFNAC in most of them because we had a lot of these. But if they were not tolerating or there were other reasons, then I gave NIV. And I gave NIV through the invasive ventilator, not the portable pressure ventilator.
Because you're right, HFNC is ideal, but realistically in our country, many centers do not have enough HFNC. And
people have been using NIV for many years. So every center, a lot of portable pressure ventilators.
So that's why, how do we limit in? This is really for those people using more of NIV. How do you limit?
If you are using there, as I said, you can just give a CPAP through this machine. Keep IPAP and EPAP almost equal, like 10, you can keep that. But if you are using a BiPAP, it depends. Usually these patients will require 5 and 6 of EPAP and about 4 to 5 of pressure support. That means just 4 and 5 above this. That was the initial setting in most of these patients. That is how I would give them a lowest possible, because the tidal volume is not seen on a portable pressure ventilator. So you have to examine the patient if he's making the enough respiratory excursions and that lower pressure support and FiO2 to maintain 88 to 92. The WHO has recommended that you should maintain initially 94 and during the maintenance period, you maintain above 90. So that is what we were usually following in these patients.
Does anybody else have any views, any other tricks to minimize?
I have some experience to share regarding use of, it's very interesting to know that you can use those portable ventilators. Actually, due to, again, logistic and infrastructure limitations, we did end up using a lot of BiPAP machines, both in the high dependency units and also in the second wave, we also had to use this in the ward level also. And we got good results actually with most of these patients who had, as Dr. Chawla rightly said, those who are not very tachypneic, the respiratory excursions are not too bad. We have to continuously assess them, that's right. But they did also manage with BiPAPs when there was a paucity of invasive ventilators or even portable ventilators. So I think the results were good, even those kind of patients, but we have to cautiously choose that cohort of patients.
Thank you. So next, the question that Dr. Rajesh talked about already with the L type and H type. So Kedar, first to you. I mean, Gattinoni introduced this concept of the L type, the low compliance, low elastance and high elastance types. So obviously, so first of all, the question is whether you believe in this L and H type, and if you do you have different strategies for depending on what type the patient is in, or as Rajesh said, they're all the same, and your strategy would be the same irrespective of what phenotype it belongs to?
Meaning, when the pandemic started off, it was a good theory to understand things. But finally, as Dr. Rajesh said, that it's a progression of the disease. So in any ARDS, you will have some amount of L type and some amount of H type in the same lung in the same patient. Okay, so it's an intermix of things. But yes, we predominantly have seen L types rather than the H type. So theoretically and making us understand the ARDS concept and COVID becomes easier, the CARDS ARDS lung. And we did see these differentiating points. So they were predominantly L types or predominantly H types, and the L types finally worsened to the H types, especially those patients who were ventilated for a long time on NIV and were not intubated very fast. Those patients landed up with the H types later on. So the principle of treatment remains more or less the same. So obviously the patient's lung is of L types. You don't need high PEEPs. Okay, your plateau pressures are good. And but in the H types, obviously you tend to use the ARDS net strategy. And there you require recruitment, you require proning more often. Whereas in the L types, they are those compliant lungs which hardly trouble you. We go off. We can ventilate them on PEEPs of 8 or 10 not more than that. And they really do well. Their FiO2 requirements come down very dramatically. And they may require odd proning episodes or odd proning cycles, but they recover very fast. So I am not a great believer in the L types and H types, but yes, meaning understanding the concept becomes easy. At the same time, I would say that it will be predominantly L types or H types, and there will be always an intermix of both in at any given point.
Thank you, Kedar. So, Dr. Fua, what are your views? Would you ventilate them differently, or you don't think or you agree with Kedar that there is no such difference?
Well, I agree. The lung safe study, which was done pre-COVID, they looked at the compliance and they found that 1 in 8 of patients without ARDS had what's known as the L type, meaning high compliance. So possibly it's COVID, there are more patients with L types because there's a lot of endothelial dysfunction, and as a result, the VQ mismatch is severe rather than terrible lung weight due to alveolar edema. But even that, when Eddie Fan from Toronto reviewed the literature in COVID, aside from studies from Catenoni's group, most other studies showed that there's not that much L type. So I would think that yes, it does exist, but no, it's not unique to COVID. It is just the whole spectrum of disease from mild to severe, from early to late in ARDS, with or without COVID. For me, I would think that the management, the main difference to me would be how much PEEP would I use. If the patient has got low elastance, i.e. high compliance, it is less likely that he or she would benefit from high PEEP. And so if the chest X-ray is quite clear, not much edema, I would probably use a lower PEEP. On the other hand, if the patient has got high elastance, low compliance, terrible bilateral opacities, I'll probably use a higher PEEP. Other than that, tidal volumes, I would always keep it low. Proning, I would always start it early. In a mild ARDS, nowadays we do awake proning. In severe ARDS, we ventilate them, intubate them, sedate them, and pronate them. So those do not actually change. So to me, the main difference is how much PEEP would I apply.
Thank you, Dr. Fua. Anybody else has any views, or we move on to the next question? So the next question actually, is actually correlated to what we talked about the L type and the H type, though we all agree. Saurin wanted to say something. Saurin, what did you?
Actually, I fully agree with Dr. Kedar about that L type, H type, that is very sound in both the theory as well as the exploration. It is the same disease actually. Clinically, it is for the clinician. I think it is not so important. Most important is what is happening in the bedside. So that is the most important. And the same disease, when they are going through the defined phases of that disease, so automatically the behavior, as the time passes, the behavior will change. So that's why the importance. And COVID actually we are observing very closely, and we are following from very beginning how the lungs is behaving. But in a non-COVID ARDS, maybe we have missed that opportunity to find out that type of window where the lung compliance is high or L type is A. So it is a kind of overlap, and we should basically approach, as already we are discussing, that approach in the bedside will not be much different, because finally the treatment aspect as well as the therapy, if we consider the amount of PEEP patient is requiring, that will remain more or less similar to the non-COVID, or whether it is L or A, it hardly matters.
Thank you. See, the next thing, of course, the answer to what you talked about, Doctor, we all said the L type, or the initial phases, the lungs are more compliant, but we all say that we're going to use low tidal volume ventilation. But in this situation, quite often, as all of you have said, the patients have a very high respiratory drive. So they require very high tidal volume. So you obviously need to judiciously use sedation and paralysis, especially even in the spontaneously breathing patients, even patients who are not ventilated. So Dr. Neeru, first, what would your strategies be? People have talked a little about sedation. So what would your strategies be? First on patients on NIV, and then of course on patients on invasive mechanical ventilation.
On NIV, so sir, I just released the anxiety. No need of any.
So which drug would you use? What was your treatment of choice?
Sir, Dexmed we used in some of the patients, and they are awake, they are responsive, not much sedated, to reduce their anxiety and the patient-induced self-injuries to the lungs, sir. And for invasive ventilation, for moderate to severe cases, And in patient requiring, they may need for prone ventilation, we used sedation and paralysis both, sir.
No, because
And,
like,
our target was to get a PF ratio of more than 150. Till then, we continued our paralysis and sedation with these patients with multiple proning cycles also.
so you would resort to paralysis pretty quickly, or you would wait for.
Yes, sir.
So because most people
To
tend
maintain to get a target of achieving a PF ratio and this thing, sir. In moderate to severe cases, we would go for paralysis and sedation.
Sharmili, what are your views about
No, patients who were NIV to allay anxiety and that to suppress the increased respiratory drive, which could prove harmful. We're using low doses, titrated doses of fentanyl or morphine because of the availability, and dexmedetomidine in some cases as appropriate. But once the patients, in moderate to severe cases, when they got intubated on invasive ventilations, we have a decision to prone them was early. And so once we prone them, first 48 hours, invariably we put them on sedations, mostly using opioids like, again, morphine, fentanyl combinations, along with some paralytic agent. Mostly you use cisatracurium or atracurium combinations. But after 48 hours, actually, we gradually wind off and stop paralysis. We continue sedation. First 3 to 5 days, actually, we do not advocate reducing or abruptly stopping the sedation at all, as per practices in non-COVID ARDs that we're doing, because they were requiring very high levels of respiratory parameters to maintain the blood gases and all synchrony. So suddenly, if you're disrupting them, they went into such a asynchronous state that you would really struggle to bring them back. So I think for 3 to 4 days, I do not stop sedations, and thereafter, you have to do some kind of neurological examination, mostly resort to the checking the pupils. And after 3 to 4 days, we start reducing the sedations and check their neurological status. So I think that was one thing. But one experience that we gathered is some of these patients, when if you have started winning their, stop the paralysis and started winning their sedations, some of them, if they have an interesting component of reactive airway disease or active or inactive COPDs, they tend to have bronchospasms, which is not very well appreciated by the staff who are already in PPE. We are not using our stethoscope very often. And some of these patients, when they go into a stage of patient ventilator dysynchrony, some of them actually by the junior doctors or staff, they were given paralytic agents. But these are the category of patients who suddenly go into a state of autotherapy or air trapping, and they actually crashed. So thereafter, actually, we made it sure that some patients, when you're especially winning the sedation and there is a dysynchrony, we have to exclude that there is an active bronchospasm. Because if you're giving even a shot of paralysis to them, they are the patient, they tend to crash and end up in cardiac arrest. Other than that, our practice was same as we do for non-COVID ARDs as well.
No, I mean, I'd like to view of everybody else on this also, because I know, at least from my own experience, I realized that especially the early phase of the, the lung, when they were ventilated, they had a very, very high drive. And if you try to limit the tidal volume to 4 to 6 ml per kilogram, it was impossible to ventilate them without paralysis. No matter how much sedation we used loads of sedation, but we had to paralyze them for several days together. That's, I think, 1 or 2 days of stopping paralysis did not work. So I'd like to know the experience of the other people. So then it was a balance of whether the risks of paralysis was the risks of high tidal volume. So, I mean, we erred on the side of paralysis. Now, I would like to know whether what the rest of the people did. Did you all err on the side of accepting slightly high tidal volumes and avoiding paralysis, or did you all paralyze them everywhere just to prevent potential lung?
Can I answer?
Yeah, right.
This was very difficult. All of us know that many of these patients required very high FiO2, even in prone position, and it was not possible to wean off paralysis from these. Their FiO2 would increase and their drive would increase. So what Dr. Sharmili is talking about, the ideal patients who are like, what would you expect? But many of these patients required very high FiO2 in prone position, ECMO not being available. So we had to continue paralysis for a long time. And many of them did survive. Of course, they had a prolonged course with critical illness neuropathy. So this group of patients, also we are still struggling with few of them.
Arvind, you want to say anything or any other views?
Yeah, I mean, I fully agree with Dr. Rajesh that we prioritize more controlled ventilation, as you also said the same thing. Rather than putting the patient through more lung injury, high tidal volume, it's better to paralyze and take control and then live with the side effects of long paralysis.
Thank you. finally, I mean, last question from us.
Can I just add one comment?
Yes.
I agree. I mean, COVID ARDS patients really difficult to ventilate. But what in our practice, what I meant to say is that after 2 to 3 days, we actually tend to stop our continuous infusions, and we are giving them on and off boluses as required rather than giving them continuous. The reason being, in the first wave, actually, we found that most of the patients who became negative and came to the non-COVID ICUs later on, they were confronted with severe critical illness polyneuropathy, which actually, impeded their successful weaning from ventilation later on. So in the second phase, actually, we practice this type, giving it for shorter time and giving it as boluses as required. But some of the patients, I do admit that when they did not do well and after stopping paralysis altogether, if they went into severe dysynchrony requiring again rise in FiO2 and high airway pressures, we had to paralyze that. But as a general policy, we try to limit it within 2 to 3 days.
Thank you. So Saurav, the next question is for you. Do you think prone positioning, I mean, we know it improves oxygenation, but do you think it has any role at all in whether it is spontaneously breathing patients or on the ventilator? Does it in any way tend to reduce barotrauma or volutrauma, or it is just for improving oxygenation?
The prone position, both for the awake as well as intubated and ventilated patient or invasive ventilated patient, there may be a role for the prone position because of the thing that there are also some, if we think about the recruitment as well as the patient redistribution, it is more homogeneous when the patient is in prone position rather than patient is in supine position. But to establish this hypothesis, definitely it will be a bit difficult, but definitely in animal model that is there, particularly in animal model, once that model is in prone position, there is more redistribution as well as the pressure, whatever pressure is generating in the ventilator. So taking care of the play to mean pressure or whatever it is, the transpulmonary pressure. So that can be better cared of. So from that, we may extrapolate in our clinical practice. And not only that, once the patient is in prone position, sometimes this pressure also, other than oxygenation, there is also changes in the sum of the pressure parameter in the ventilator. So that way it may be helpful. And only problem is that because the patient, we cannot keep the patient for the this kind of study is not possible. So that is the only problem, because we cannot keep the patient prone for more than usually 12 to 16 hours. So again, patient is going to the supine position, but definitely it might have some role once we are putting the patient on prone position in terms of the prevention of the baro as well as volutrauma. That's what I personally feel.
Thank you. I think that brings me to the end of the questions. If there's anything else, any other words of wisdom from anybody else in the panel? We got 3 or 4 minutes to go. So anybody wishes to say some final points before I wind up? Nobody's raising the hand. So sure, I'll have to pick up one by one otherwise. Neeru hasn't spoken much. So any final words?
Not much. Just like a bedside assessment is most important, whether it is mild, moderate, severe. Nothing is like documented. Only the patient present status and how we have to move. Sir.
Thank you.
And how this is the deciding factors in everything, whether to use NIV or ventilation and to reach the targets.
Thank you, Neeru. So
I think,
yeah, please, Rajesh.
I think stick to basics. That's the most important.
Yes, sir.
And if you do invasive ventilation, do a lung protective strategy and follow what you've been doing all these years. And as she said, neuromuscular blocking agent, as per the new sepsis guideline, also now they say, don't give an infusion, give it boluses, because after the Rose trial, there is a little doubt. So give it bolus. But of course, we still continue for first 48 hours and then probably if required. And I hope the COVID doesn't come back. That's the last.
Thank you. Any other words of wisdom before I think we're running out of time now, but otherwise, I think we've had a very good session. Thank you very much, all of you, for all your insights. I think this has been practical and has been useful to everybody. Thank you very much. And this will be relayed, I think, on the 23rd in Hall F. So if you'd like to be here and be there for the question and answer, welcome, please. Thank you very much, everybody.
Thank you.
Thank you, sir.
Thank you. Thank you, my co-panelists.
Thank you.
Thank you.
We are very happy to have Professor Mitch Levy with us, who has kindly agreed to express his views on some of the issues that we discussed in this panel discussion. Dr. Mitch Levy, of course, is one of the most recognized and respected faces in the field of critical care. He is professor and chief of the division of pulmonary critical care and sleep medicine at the Warren Alpert School of Medicine in Brown University in the US. And so I mean, he has of course had several achievements to his credit, and most importantly, has contributed to several practice-changing papers and guidelines in the field of critical care. Of course, the most recent of which is the Steroid Sepsis Guideline 2021. So without much more ado, I'll ask him some of the questions that we discussed in this discussion. So first question, Professor Levy, is do you believe in this concept of PCLI or patient in self-induced lung injury, which Professor Gattinoni said this contributes to the progression of lung disease and COVID-19 in spontaneously breathing patients? And if you do agree, how do you think we should try to limit PCLI in patients on NIV, especially on NIV?
Yeah, that's a great question, Ashit. And you know, I have tremendous respect for Professor Gattinoni, of course, as all of us do. I will say that the concept of PCLI has just been introduced. I do think that patients can induce through wide intrathoracic swings self-induced lung injury. And we also know that patients are very, very difficult to sedate when they have COVID-19 and early pneumonia. In addition, we know that the first phase probably of COVID ARDS is a pulmonary vascular injury. And so there's no question that patients are hypercoagulable. They have all the autopsy studies, most demonstrate microthrombi in the lungs early in ARDS and late. And so the concept of self-induced lung injury is very real, and I believe that it exists. The big challenge is, when do you paralyze and sedate patients who have a high respiratory drive, want to generate high tidal volumes, and therefore we either sedate them or paralyze them in order to bring their tidal volume to 6 cc's per kilogram? And I'm not sure, nor do I believe that the answer is completely settled in the literature. I definitely think that wide intrathoracic swings can induce lung injury, worsen lung injury in COVID ARDS. However, I do not automatically sedate or paralyze patients who have spontaneous respirations early on in ARDS. I think that most commonly, I think the most important thing is to individualize therapy. So even though I believe, and many of us believe, that high PEEP levels are beneficial in patients with ARDS, many early COVID-19 ARDS patients don't tolerate high PEEP. Their oxygen saturation drops. They have wide intrathoracic swings and have high intrathoracic pressures. And so for those patients who do not tolerate high PEEP, I don't force a high PEEP. And if their respiratory rate goes much above 35 and their tidal volume goes particularly high above 8 cc's per kilogram, I do paralyze those patients or sedate them and try to get to 6 to 8 cc's per kilogram.
Thank you, Dr. Levy. The other question actually was, in our country, I mean, quite often we tend to use NIV. I mean, though I understand literature says that if patients are failing HFNO or oxygen, you need to intubate them. But then, because of whatever reasons, NIV was being used quite often in our country. So such patients, of course, also have an increased respiratory drive. You obviously can't paralyze such patients. So what would you do? One, of course, about sedation. What sedatives would you like to use? And any change in the settings on non-invasive ventilator to sort of try and limit PCLI?
Yeah, we talked about this in an earlier panel session, and I think the challenge of non-invasive ventilation is, we talked about this in an earlier panel session, and I think the challenge of non-invasive ventilation is often driven by the limitation in availability of high flow nasal cannula. So our preferred method of ventilating patients who don't require mechanical intubation, intubation mechanical ventilation, is high flow nasal cannula. In the absence of the availability of HFNC, high flow nasal cannula, then we do use non-invasive ventilation. I think the note of caution I would sound is if we're using non-invasive ventilation as a way of avoiding intubation and we wait too long to intubate these patients, then I think we cause more harm. I'm not afraid to intubate patients when they need it. And when I say when they need it, in our institution, we go up to 40 to 60 liters per minute in high flow nasal cannula. And if they, again, have very high respiratory rates and very high volumes on non-invasive ventilation, then I wouldn't hesitate to intubate those patients. We don't tend to use non-invasive ventilation for very long in patients who have severe COVID ARDS.
But would you try sedation in such patients? What sedative would you prefer? I mean, in an attempt to reduce their drive or the tidal volumes?
Yeah, another great question. We try to avoid benzodiazepines as much as possible. In general, that's consistent with the Society of Critical Care Medicine COVID and non-COVID guidelines. So we tend to use fentanyl and or morphine, opiates, and we will often use Seroquel or an alternative to benzodiazepines that are also sedating medications. So we try to avoid benzodiazepines, but at the same time, having said that, we all know these patients with COVID-19 are incredibly difficult to sedate. And we often resort to benzodiazepines if we need them in addition to opiates to sedate patients, either with mechanical ventilation or a high flow nasal cannula or non-invasive ventilation.
Thank you. Finally, of course, you already discussed this in, I think when you spoke before. So you believe in this L type and the H type, and do you think we have different ventilative strategies for these, or you don't think it matters whether they're the so-called L type and the H type?
Yeah, I try not to concentrate on the two phenotypes. As I've said, I have tremendous trust and respect for Professor Gattinoni. I think a little bit too much has been made of the two phenotypes. We often find that in the long run, by the end of mechanical ventilation, patients are pretty consistent with classic ARDS. That is, they require higher PEEP, they need proning, and we still try to limit their tidal volume. And so I feel that the phenotype, the H phenotype, may be true early in ARDS. And I think, as I said before, in patients who won't or can't tolerate higher PEEP because of rapid desaturation, I tend to use a lower PEEP, and I don't hesitate to intubate those patients early if I need to.
Thank you very much, Professor Levy, and nice talking to you. And we'll, of course, I don't think there'll be a time for questions, but thank you very much for agreeing to take part in this and for a valuable opinion. Thank you very much.
My pleasure, and I'm happy to be here always.
Thank you. Well, hope we can see you in India soon personally. In person.
Yes, me too. I hope that very much.
Thank you.
Yeah. Thank you. Bye-bye.
Bye.
Thank you so much, sir. Thank you for such a comprehensive session. I now hand over to Dr. Utkarsh for the next session.
Thank you, Dr. Ayushi, and thank you to all the speakers. Now moving forward, we'll start with the first thematic session of the day. The session will be chaired by Dr. Girish Mathur, Senior Consultant, Internal Medicine, Kota, Dr. Nirmal Choraria, Chairman and Chief Pediatrician, Nirmal Hospital, Surat, Dr. Arpita Saxena, Associate Professor, Department of Anesthesia and SNMC, Agra, and Dr. Anup Dikshit, General Surgeon and Emergency Department Specialist, SPIMS Agra. Now I would request Dr. Girish Mathur to introduce our first speaker.
Good morning, friends. At the outset, I express my thanks to Dr. Narendra Rungta, the man behind World Conference on COVID and Critical Care. Our first speaker is Dr. Rekha Das. She will be speaking on nutrition in COVID and ICU. Dr. Rekha Das is Professor and Head, Department of Anesthesia and Critical Care, Infection Control Chairman at Acharya Harihar PGI of Cancer, Cuttack. Dr. Rekha Das is Secretary of ISCCM Cuttack Branch. She is President ISA Odisha State Branch and is editor of Odisha Medical Journal. I invite Dr. Rekha Das for her presentation.
Good morning. At the outset, I would like to thank the organizers for giving me this wonderful opportunity to speak on this podium. My topic is nutrition in COVID ICU. Nutrition, as you all understand, is an important element of care in critical illness because it has several benefits. It maintains the GI function, the immune defense, the muscle mass, and functional performance. And COVID, as we all understand, is a systemic disease that goes well beyond the lungs and profoundly affects our immune system. And therefore, nutrition remains a key component of care here. COVID, the status in COVID is a dynamic process. It keeps on changing. And therefore, nutritional care needs re-evaluation and implementation with the aim to prevent, diagnose, and treat malnutrition. The risk of malnutrition in COVID-19 patients is related to the chronic pathologies, the diabetes, the cardiovascular disease, hypertension, and the cluster of polymorbid conditions, the old age, even obesity, which is associated with increased risk of malnutrition, as well as the severity of the disease, which we witnessed in this second wave. The young adults who were obese suffered a lot. Severe respiratory infections, which increases the ventilatory work of breathing and energy expenditure, resulting in hypercatabolism and protein energy utilization. Its medical management, like the organ support, sedation, ventilation, length of stay of more than 2 days, all can lead to loss of skeletal muscle mass and poor function and outcome. Even decreased food intake due to GI symptoms, loss of appetite due to altered smell, taste, dyspnea, stress, the psychosocial stress, the stress of confinement, plus other factors in ICU like limited mobility compounded with inflammation, sepsis, and hypermetabolism, the organizational problems that prevents attendance of supply of food and intake due to barrier nursing and infection protocols, the nutrition delivery, which is also affected within the body due to GI and liver involvement. Moreover, we all understand that the urgent respiratory and hemodynamic support for which the patient is getting admitted into the ICU receives the priority, and therefore nutrition is sidelined. ICU survivors stay for a long period. That makes it more vulnerable to the malnourishment. Prioritizing nutrition in pandemic is also difficult. All this leads to delay in implementation. And to overcome this, we need to integrate nutrition in the overall therapeutic strategy and keep dedicated dietitians for COVID-19. So what is the nutritional risk screening, which is important to identify the high-risk patients? The basic nutritional screening tools, which are validated like the MUST, the NRS 2002, which are weight specific and BMI dependent, that cannot be relied on because the body contains a lot of fluid. The Nutrix score, which is very much pertaining to the ICU assessment, has limited applicability in a pandemic situation. There are staff safety concerns, and there is so you cannot conduct a nutritionally focused physical examination of the patients. So you need to depend on clinical observations and laboratory tests like the disease state, the food intake, age, communication with the attending nurse, and hypoalbuminemia level, the laboratory parameters like the prealbumin also. And Nutritional screening should be conducted, ensuring the staff safety, minimizing bedside assessment through coordinated care and remote working arrangement. That should be the bottom line when doing a nutritional screening or assessment. Calculation of nutritional requirement normally is done by measurement of energy expenditure like the indirect calorimetry. But in COVID, this has a limited use because to limit the staff exposure to virus, the potential spread of the disease, equipment contamination, and to minimize the workforce demand. So you need to depend on the predictive equation, but the most commonly practiced in ICU is the weight-based formula. The energy delivery should be 20 to 30 kilocalorie per kg per day, and the protein delivery should be 1.2 to 2 gram per kg per day. And the ratio of calorie delivered by fat and carbohydrate should be 50:50 in ventilated patients, but otherwise it is 30:70. So when you start a feed, you start at a low percentage, at a 25% of the actual desired goal to prevent risk of refeeding syndrome. And then you progressively increase the energy and protein delivery over the first 4 to 6 days to reach a final energy target, which in critical ill patient is usually 80% of the total requirement. And continuously or frequently monitor the levels of magnesium, phosphate, and potassium, because there is a likelihood of having a low level of this and complications related to this. And remember to administer vitamin and trace element in the first 3 days of enteral or parental nutrition. Enteral nutrition is always a preferred route of nutrition. Early initiation of enteral route is advocated within 48 hours. Some say within 24 to 36 hours of admission into ICU and 12 hours of intubation. Nasogastric route is a preferred route of nutrition because nasoenteral route increases the risk of exposure. Nasojejunal, nasoduodenal should be avoided. And if it is given, it is to be given only when the patient is intolerant to the nasogastric route. A continuous enteral nutrition is always preferred. It decreases diarrhea, staff-patient interaction, and prevents aspiration. And patients who are on stable and low dose of vasopressure, you can still give them by nasogastric route, but you must start with a tropic dose. But if there is uncontrolled shock, you may withhold enteral nutrition temporarily. And then again, try to resume it later. Diarrhea, patient is having, switch to semi-elemental enteral nutrition. But recent history of diarrhea is not a contraindication to enteral nutrition. Eicosapentaenoic acid, docosahexaenoic acid enriched enteral nutrition have an immunomodulatory effect on cytokine storm, and so they may be included in the enteral nutrition. And always initiate your standard enteral nutrition with the isotonic and a high protein formula feed, which contains protein more than 20% at a rate of 10 to 20 ml per hour, and then gradually increase it to an energy dense formula. Enteral nutrient in prone position. It has been shown to be safe in terms of large gastric residue, vomiting, or intolerance. Prone position, therefore, is not a contraindication to enteral nutrition, but it should be used by continuous method and maintaining a head of bed elevation of 25%. Metoclopramide may be used to prevent gastroparesis or vomiting. And if you have a good expert team, there may not be any necessity to withhold feeding before proning. But in most centers, there is a need to hold enteral nutrition 1 hour before the proning procedure. Enteral nutrition in ECMO should be initiated with a low dose and slowly escalated to achieve a high energy protein diet. What are the nutrition related aerosol generating procedures? Feeding tube placement is an aerosol generating procedure. Therefore, you should conduct it with the patient sedated or paralyzed, and placement of nasoduodenal or nasojejunal tube may be challenging, and if it has to be done, it has to be done bedside. But if it is too much of an exercise, it is better to go for parental nutrition. But whenever you are doing a tube placement, be careful that the patient doesn't buck or cough and is well sedated and paralyzed. Gastric residual volume measurement is not required in patients who are on stable hemodynamic parameters or low dose of vasopressor and in prone position. It should only be done when patients need a high dose of vasopressor or are unstable. Cluster care. One form of cluster care is administering modular protein or other protein supplements at one time instead of divided doses, which limits the nurse exposure to the patient. Coming to the refeeding syndrome and propofol associated complications. Refeeding syndrome is a metabolic disturbance due to reinstitution of nutrition in a starved, severely malnourished, or metabolically stressed patient. And COVID patients are vulnerable because they're old, polymorbid, they have pre-existing malnutrition, they usually have a low or no food intake for 5 days prior to ICU admission, and they might be having abnormal electrolyte due to diuretic treatment or dialysis. So whenever you are starting the feed in this patient, you need to measure the plasma potassium, phosphate, and magnesium within 6 hours of nutritional support to detect and treat the low values, and then keep on monitoring them. And start with a low protein and calorie and then slowly increase. Propofol infusion syndrome is seen when propofol is given in a high dose of more than 4 milligram per kg per hour for more than 48 hours. It can lead to hyperlipidemia and many other dreaded complications. Hyperlipidemia is also seen when patients are given soybean oil that contains omega-6 fatty acid that gives rise to a strong inflammatory response. So fish oil may be used instead, and you have to keep monitoring the triglyceride level when you are giving these substances. Parenteral nutrition is indicated where enteral nutrition is impossible or contraindicated, or it is insufficient. The indications, absolute indications, are persistent ileus and persistent hypotension. Supplemental is given when patients are on HFNC or NIV, they are underfed, in prone positions, if there is sometimes vomiting, in severe hypoxemia. And if you are giving through a central line, that is the total parenteral nutrition, your osmolality is usually more than 900. But if it is low, then you have to give it in the peripheral line. Or if you are using the peripheral line because your central line is clustered with many drugs, then you have to see that your osmolality is less than 900. It should be started after 4 days, not earlier. And the energy source here comes from the dextrose and lipid, and you have to maintain a ratio of 70:30 or 50:50 if the patient is mechanically ventilated. In sepsis, always remember to limit the dextrose in IV by less than 4 milligram per kg and lipid to less than 1 gram per kg to prevent sepsis. And we always ensure the electrolyte levels that you are giving and supplement vitamin and trace element when you are giving parenteral nutrition. Thus, to summarize, nutritional management in ICU follows the basic principle of nutritional management followed by the American Society of Enteral and Parental Nutrition and the European Society. Enteral route should be the preferred route of nutrition, which may be either oral or enteral. And you must start at a low dose and progressively increase your dose in the next 4 to 6 days. And always avoid refeeding syndrome by continuous monitoring of magnesium, phosphate, and vitamin level, and supplement your trace elements and vitamins. Enteral route nutrition should be initiated early, within 48 hours. Enteral route nutrition should be nasogastric ideally, and it should be continuous. Estimation of GRV should not be a routine practice. Patients who are intolerant to gastric feed may be started on parenteral feed, but you should avoid fluoroscopy or endoscopy guided post-pyloric tube insertion because they are aerosol generating and they may contaminate too many substances. Cluster care consists of optimizing nutritional delivery to patient while minimizing exposure to ICU staff and avoiding contamination of many equipment, and there should be the practice everywhere. Thank you.
Thank you, ma'am, for such a wonderful talk. Now I will request Dr. Nirmal Choraria to introduce our next speaker.
At the outset, I would like to thank Dr. Narendra Rumta and the whole team of the organizers of World Congress. This topic is motivating my team during COVID, and the esteemed speaker is Dr. Sarmili Sinha. She is a senior consultant, critical Care Medicine, Apollo Hospitals, Bhubaneswar. She is the EC member of East National ISCCM, member of SCCM, around 50 guest lectures and 50 publications in index journals and books chapters to her credit. Dr. Sarmili Sinha.
Good morning, my dear friends, colleagues, and esteemed chairpersons. I'm Dr. Sharmili Sinha from Bhubaneswar, and at the outset, I would like to congratulate the organizing team for conducting this World COVID Conference, the first of its kind, focused on COVID-19 and all aspects of critical care. And immense thanks for this opportunity. Now, since this COVID-19 has started affecting the entire world, India faced its first case in the month of January or February 2020. And since then, millions of cases have exploded. So in those beginning days of, say, February or March 2020, a humongous task was ahead of the government and both the private healthcare sectors in terms of formulating policies and strategies as to how to tackle this pandemic. Because the main focus or the concern challenge was not only to treat the diseased person who has been affected with COVID-19, but also the immense challenge was how to contain the spread of the disease, because at that point of time, it was known that one person who is affected with COVID-19 can infect another 10 to 15 persons. So for a country like ours with 130 million population, it was a mammoth task for us. And as we know that according to one of the last surveys conducted in 2015, 85% of the healthcare in India was being catered by private healthcare sectors. Obviously, the numbers would have changed by now. But nevertheless, it was a very difficult task ahead of both public and private healthcare sectors. So how we face these challenges and how we could motivate our teams to take part in as warriors in this war against pandemic, we'll share in the next 10 to 12 minutes. Really a very unique situation for us, because never before this actually mankind was confronted with this kind of war-like situations. So the challenges faced were divided under broadly 4 categories. First and foremost is the psychological and the emotional one, because this is, I would say, one factor or one challenge which had all strata of the society have faced, both the healthcare or non-healthcare workers. The others were related to personal infrastructure of healthcare facilities and administrative aspects. Regarding the personal, actually, all kinds of healthcare workers were affected immensely and profoundly during those initial days. In the medical team, it's also starting from senior consultant to consultant, even the junior most residents, the interns, they're part of it, because everybody had an immense fear of getting how to handle the infected patients, and also there was a fear of contracting the infections by themselves. Nurses and technicians as a team, I would say, they have been the pillar of this COVID war against COVID, and they are the ones who have actually stayed by the patient's bedside along with the junior doctors. They have played a major role in the management of these patients in intensive care units. Regarding the allied health staffs, which includes physiotherapists, dietitians, and patient care attendants, housekeeping staffs, they were also actually very difficult to be convinced during those initial part to take part in the care of this COVID-19 patients and to work inside the COVID units. A physiotherapist on a daily basis at least visit the unit twice, and it is also very essential for those patients who are on a ventilator that they get chest and limb physiotherapies as part of their weaning process. Dietitians play a vital role in determining their total calorie and protein intakes, which is also a vital role. Patient care attendants and housekeeping staffs are imperative, are essential for running of any unit or intensive care units. Now, another challenge which we faced for the first time, and I actually confronted it first time in the last 17 years of my critical care practice, was regarding other specialists or my co-specialist in the hospital, that they were also quite reluctant initially to visit the COVID units. Starting from all specialties, cardiologists to neurosurgeons or neurologists, and even other paramedic workers like the radiographers who come on a daily basis to the unit to x-ray the patients, along with their mobile X-ray units, they also started bargaining for particular slots to take the X-rays. And it was going to affect the care of those patients, especially those who are already hooked to the ventilator. So to know the progression of the disease status, many times the X-rays were required and the radiographers were very difficult to be convinced about it. Even getting imaging for this patient was a challenge, because many of these patients who required CT scans of the chest or CT scan of other parts of the body due to variety or other dominant presentations like coma, or if they have an abdominal problem. So wheeling these patients out of the COVID units to the imaging suite was also a challenge. And radiologists are also actually quite apprehensive during those initial days. And nonetheless, the administrator also had their challenges of coping up with the stress, and the regular administrative rounds which were happening in other times of the year were not happening regularly. Rather, they were kind of confined to their own offices. So the issues were far too many. The first and foremost was the fear of contracting the infections, and that was the sole thing which was guiding, completely grasped everybody's mind. And then was unfamiliarity with the personal protective equipments. Now, for decades together, we have learned about this personal protective equipment. It is nothing new to the medical fraternity. And actually, in fact, the surgeons inside the operation theaters have been wearing these gears while they operate on this HIV or other infected patients in the operative units. But we are not used to wearing this PPE on daily basis inside the intensive care units, though we were part of it, like gloves or at maximum the mask. But in wearing the entire PPE was something very new to the entire medical and the paramedical team. So many were actually uncomfortable in wearing the PPE properly due to mainly the sensation of suffocation. So if you're wearing double mask along with a head shield, or depending on the type of PPE you have, people were feeling suffocations, and many had suffered from claustrophobia as well. And now for the team of paramedics who are doing bedside duties, at least the duties were divided in the shifts of 6 to 8 hours, or some were given even 12-hour duty shifts. So there was hardly any scope of breaks during this entire period of duty. So that was also adding to their fatigue, mental and physical fatigue. Now, COVID allowances was actually a practical issue, and initially I think most of the units across the country, be it public and private sectors, initially they had to announce COVID allowances, some kind of to incentivize the staffs to participate in care of these COVID-19 patients, both in the ward and in the intensive care units. Now, for a long time, we also faced, kind of bargain from the staffs, or we had trouble in convincing them regarding the period of quarantine after duty hours. So some were, and policies were varied across the country. Some were giving 7 days off after the duty, some were given 12 or 14 days off post duty. So that was also something which was not decided uniformly. Again, the authorities were asked to arrange for stay and food arrangement for these staffs which were doing COVID duties, because initially those days they obviously could not go home because the scenario was not clear, and there were strong advices and many guidelines were there to keep them off in isolated places. So when there was revenue loss for these private healthcare sectors, arranging stay and food for these patients, for their staffs in the separate setups after duty was also a big challenge for them. And there was a prevailing uncertainty among healthcare workers in regarding their healthcare cover in case they get infected with this COVID-19 illness during the work hours. Though there were declarations by various state governments regarding their cover and compensations, but it was unclear to large extent in the private healthcare sector for some time initially. So the best way was to lead by examples. The leaders of the hospitals, starting with the administrators or the healthcare leaders or the unit heads, had to demonstrate ownership of the unit and the task of running the COVID units, both intensive care units and the COVID wards. Training and teaching by audiovisual aids was a main tool for continuously improvising their skills and building their confidence to handle these patients in the most effective way, while at the same time keeping themselves or saving oneself from contracting the disease. So there were a lot of emphasis on proper way to wear the PPEs. Steps for donning and doffing, I think, was the most important tool or the way to teach staffs how to protect themselves first from getting the infections, and then if they are doing it properly, they were also to be convinced that they are not going to spread these infections to their nearer dear ones or to their friends if they are staying in the hostels or the hotels during this quarantine period. So counseling of the staffs regarding the arrangements that have been done for them in case they fall sick or during the duty hours or after the duty hours also played a important role in convincing them and winning their confidence. And at times also, many times we have to reiterate the principles of ethics and commitment for the healthcare workers towards the healthcare establishment and for the patients. So it also had sharing the success stories, because initially, if you remember, like around 90 to 95% of the patients were having mild disease, and if they were coming to the hospital and after their wards, if they're getting discharged successfully, those stories they used to share with the doctors, and if you're sharing the stories with our staffs and nurses, they were really encouraged about it. So acknowledging and appreciating the teams periodically had a huge role in boosting their morals in the unit, and we were also celebrating it off and on in small gatherings, though in different corners of the hospital, and through also social media and praising each other. So that helped us keeping the moral up all the times. Of course, they were given time offs after COVID duties. And I remember one time, like there were a lot of controversy regarding ivermectin prophylaxis. Some of the states had already adopted it in their guidelines as a prophylaxis, and while some have not. But I remember that we also actually, when we started the bigger COVID ICU, we had to call the nursing charges and personally counsel them, because some of them were actually unwilling to participate. And actually we took personal steps to convince them, and also advocated if they agree they can take ivermectin prophylaxis, because vaccine was not in the scenario at that point of time. Though it was controversial, some of them actually took it and were later very thankful to us that we gave them, and most of them actually did not contract the infections later on. So this is a dance video of a doctor who was, devised this way of entertaining his colleagues and patients during his duty hours. This is a doctor from AIIMS Bhubaneswar, and this went actually viral in the social media, and after that it was quite amusing to see him performing during the duty hours. So this is the best way to keep your mates happy and pleasant during those difficult times. So also, while we talked about leading by front, like some of us, while we also participated in spreading awareness in the TV or through radio, this actually, went viral among our staffs, and it did definitely helped them boosting their morals, and they felt proud and started taking pride in what they do. And they also expressed their happiness and joy that they're part of our team. So this is a picture of a lady who stayed with us around 16 days, and she had 2 small children, and she was in a high dependency unit, and at the time of discharge, she was very happy. And her son actually wrote a very emotional letter to us, thanking that we returned his mother to him. So these kind of stories actually were definitely very encouraging for our staffs. So this is a photo of my unit where, on the occasion of the Nurses' Day this year only, 2021, where they all feel very happy, confident, staying together. So administrative issues were simultaneous and parallel. Absolutely, there was lack of preparedness, because nobody ever imagined COVID pandemic-like situations before, and neither the mankind had witnessed this kind of pandemic ever before this. So the best way to handle this was to formulate a COVID task force, which was done in our hospital, and I think that was a turning point. And thereafter, after a series of meetings, actually we started formulating our own strategies, and every challenge or whatever issue used to crop up, this was addressed by the COVID task force, and we used to find some solution to roll on. Financial implications always continue to hunt the administrative officials, because due to continued lockdown, there was loss of revenue, and it was huge. And at the same time, you had to continue to pay to the existing staffs, even if there were not many COVID-19 patients. So in those times, actually, ICCM as an organization had played a lead role. And it's one of the videos that actually was released during the ICCM, National ICCM Day on 9th October 2020, which depicts the entire story of critical care team. I'll play it for you for a while.
Code blue 508. Code blue 508. Code blue 508.
So the mission continued until date. It is continuing with certification of experiences. Many staff have gained immense experience and found it useful in further perpetuating and in the career progression. Psychological motivation has helped a lot. Now that we have come to have, there are vaccinations available. Most of the staffs have been vaccinated, which has been provided free by the state, and hospital also facilitated that. So intensivists all along have been leading from the front, and that has been emphasizing and re-emphasizing on the importance of proper PPE, donning and doffing. So summarizing our experiences of motivating our team during COVID-19, the best way was to lead by example, by leading from the front as a leader. Calm, compassionate, and caring for the team was the best approach, I believe, because at the time of need, it is the team actually, or the critical care family, which should be counseling their staffs. And if you're staying with them at the time of their need, they consider you to be a true friend. So counseling and briefing is an important step, and not only at the COVID times, at other times in our profession as well. So proactive involvement in the staff well-being at all different angles is essential, and goes a long way in ensuring their cooperation and getting their cooperation, and also long-term continuation of their services. Constant training and teaching by audiovisual aids has remained the mainstay. Now, COVID has taught us this is the best way to continue education and training at all times, even if under those kind of severe constraints. Inspiring by sharing success stories remain a very important way of boosting the morals. So motivating the team during this COVID-19 time was a monumental task, but nevertheless, it was not mission impossible, I would say. So critical care is always a teamwork, and I'm proud to share this is a team photograph of my team with me in the middle and all my dear friends and co-workers along my bedside. And this is a happy moment when we could successfully extubate an 88-year-old gentleman. He was a doctor, retired doctor actually, sitting out of bed. So this kind of things actually have really boosted the morale of our staffs. So critical care always remains a teamwork, and we have been conducting or leading this war from the front under the able guidance of Indian Society of Critical Care Medicines. Thank you very much.
Thank you, ma'am, for such a wonderful talk. Now I would request Dr. Girish Mathur to introduce our next speaker.
Dr. Mathur? Dr. Nirmal sir, can you please introduce the speaker?
So our next topic is,
can you please introduce the speaker?
Yeah, I'm interested. Our speaker, learned Dr. Vandana Sinha. She is the medical director, critical care, Ayush Sundra Super Specialty Hospital, Guwahati. And to his credit, she has got 25 years of experience in critical care, 22 years in GNRC. Dispur started the critical care course affiliation in 2013. She has been tutor for critical care training for doctors and nurses since 2013. And she is the founder secretary of ISCC on Guwahati City branch, established in 2010. So I request Dr. Vandana to start her talk.
Good afternoon. I am Vandana from Guwahati, Assam, and I would be speaking to you on the COVID Assam experience. Assam is a northeastern state of India having a population of 3.12 million with a total area of 78,438 square meter. It is a highly populous with a high populous density of 397 per square meter. There's a literacy rate of 73.13% and urbanization of 12.9%. It is connected to the rest of the country via a 22-kilometer wide strip of land, which is known as the Siliguri corridor. It has 34 districts and it is surrounded on the north by Arunachal Pradesh and Bhutan, on the east by Nagaland and Manipur, on the west by Meghalaya, and south by Mizoram and Tripura. The mighty river Brahmaputra flows through the state and divides it into the north bank and the south. COVID-19, just a few months old, unknown to mankind, gripped the state, and it was declared as pandemic on 11th March 2020 by WHO. Following the declaration, the health and the allied department staffs were energized to fight the onslaught, and a COVID war room was made functional at the office of the National Health Mission, Guwahati. The idea was to beat the menace of infodemics and sharing of the correct and latest information in form of the press release and guidelines. The Assam model, which was an effective multi-pronged strategies, which was adopted by the Health Department of Assam, it was to ensure the smooth functioning of the life of the people and to contain the disease progress. The first among the strategies was the availability of the PPE, which Assam was among the first of the state to have procured it directly from China. About 50,000 PPE landed. The next was getting up the facility. Guwahati Medical College and Hospital, being a 1,500-bedded referral hospital, was converted into a full-fledged COVID hospital with help from the WHO and UNICEF official. This was done at a war footing and it was completed within 96 hours. Participation from the private health facilities was also sought, and in Guwahati, Dibrugarh and Kachar districts, they were asked to cater to the non-COVID OPD and IPD patient. The next strategy was training of the staff in the management, in the clinical management of the COVID diseases, and the training was done at different levels with the help from the WHO and the UNICEF members. And to maintain the social distancing, the Zoom sessions and the video conferencing was done to train up the trainers at the district level. And not only that, to reinforce the manpower, we had the final year MBBS students and the nursing students were recruited. The safety and security of the COVID warriors were looked into it, so it was a mandatory of 7 days of working with a mandatory 7 days quarantine in an identified quarantine centers, following which the team would join back to work, maintaining all necessary protocols. Active support from the frontline workers was also taken, basically to generate awareness on the COVID-19 and to reach out for every household in the state in search of potential cases. This saw the flagging off of the Assam community surveillance program, and around 28,000 wards and villages were roped in, whereby these ASHA, ANM workers, multipurpose workers, along with the village headmen and the field supervisors were asked to go and look out for severe acute respiratory infection cases and influenza-like cases, along with other cases of fever. And this led to identification of potential cases. The next strategy was the psychological support, which was given to the workers as well as the patient who were admitted in the quarantine centers or were being treated through online yoga classes and also through psychological counseling. The next strategy was the massive information, education, and communication initiative, basically for mass awareness. And this was done in the form of door-to-door campaigning, distribution of leaflet, basically in the vernacular languages, and the print and medias were also used, plus there was regular briefing from the government side. This led to a good creation of mass awareness. The next strategy was in the form of ruthless quarantine with the human heart. It was made mandatory for the patient who were returning to Assam, either by the air, railway, or road, for a strict either a home quarantine or a hospital quarantine for a total period of 14 days. To look into this facility for quarantining, 5 regional quarantine centers functional at Kokrajhar, Guwahati, Silchar, Jorhat, and Tezpur was opened up, and they were created zone-wise so that the persons who were quarantined in these different zones were nearer home. Not only this, the initiative was also taken for patients who were out of the state. The first initiative was where for patients who were receiving treatment outside but could not come back home. The second initiative were for patients or persons who were abroad temporarily. The third initiative was of a financial aid to help the Assamese people who belong to either below the poverty line or the middle income groups who were staying at the different states of India. The fourth, known as the Dhanvantri scheme, was set up for those patients who were in quarantine and could not come out to get the medicines. So we had a toll-free number where the medicines were delivered directly at home. The next most important strategy was lab testing. Initially, the test was being done only for patients who had a travel history or who were tested positive or were in contact with the patients. So there were only 2 labs identified. One was Guwahati Medical College and Hospital. The other was Regional Medical Research Center in Dibrugarh. But as the restriction was open and the people started coming in, the number of positive cases started rising, and the brunt was faced by Guwahati being the gateway to the Northeast. Hence, 10 more such labs, ICMR accredited, were opened, and the number of testing went up. The states had also roped into the private labs from Delhi and Hyderabad for giving the report at earliest. Rapid testing was also taken into the being, and door-to-door testing was also done. IIT Guwahati developed a high-quality, affordable viral transport media, RT-PCR, and isolation RNA isolation kits in collaboration with RR and Animal Healthcare Limited, with inputs from Guwahati Medical College for transport testing, and this made the cost effective. This was made cost effective. Then the Advanced Institute of Science and Technology, under the supervision of Guwahati Medical College, opened up a microbiology lab where 1,000 tests per day could be done. So this all effort from the government side led to a milestone of achieving the a majority increase in the number of testing which was being done in the state of Assam. By September 2020, the first wave had started peaking, where the tests reported about 135,000 positive cases and 414 deaths. The country had gone into a world largest and strictest lockdown in different phases from 15th March to 31st May 2021, followed by unlocking. On January 1st, 2021, the Drug Controller of India approved of the emergency or conditional use of the vaccines, the Covishield and the Covaxin, and the vaccination was rolled out in phases. The program started in India on the 16th of January, 2021. The cases had dropped down to less than 9,000 per day. And despite of a strong vaccination drive, in April, the cases started to climb again. The country was hit by the second wave of COVID with destructive consequences. India surpassed 1 million active cases by 30th April, and it was reported to have 40,000 new cases per day with 3,500 deaths. We were in the grip of a major second wave. In Assam, though the fatality rate was low, it was reported at 0.36% compared to 2.7% in the country. The number of the cases were climbing high. In July, the positivity rate, which was as low as 0.07% in February, had climbed up to 2.02 in April and 2.25% in July. Vaccination was open to all. Despite of vaccination and mass campaign, the case number didn't seem to drop. The concern here was, what should we do? And why were we hit by the second wave? Obviously, there was a new strain which was much more deadlier than before. On 11th May 2021, WHO classified the Delta variant of global concern. There were mass gatherings and non-compliance of the COVID protocol in Assam. And also with the state assembly going on, this led to much gatherings and non-compliance, and the rate Assam community surveillance program had done much good in the first wave. It was called back again to flatten the increasing COVID-19 curve in the city. Counseling centers were set up in each ward of the city, and lockdown was enforced during weekends along with the night curfew. And anyone who were found violating these were charged with criminal offense, which were non-bailable. As the second wave had shown us increased severity of the illness with rapid progression and the need for specialized unit and specialized care, the government had fixed the rate for private super specialty and general hospitals. It was ranging from 4,000 to 15,000 for treatment of any COVID patients. This was to ensure that there was no discrepancy in charging the patients. As the need for oxygen increased, the consumption of oxygen, which was at 5 metric ton per day in the first wave, jumped up in July to 8.25 metric tons per day. The state required about 25 metric ton of oxygen daily. But because we had a fair supply from all sources of 37.86 metric ton of oxygen per day, we at that moment were better placed than the rest of the country. But in case the need arose, talks were already on from the government with the neighboring states of Jharkhand and West Bengal. The rates for the COVID testing was also capped, and it was very closely monitored from the government side. The vaccination drive went on. The vaccination vans were procured, and it was sent to the district, and at the district level, the campaign and the awareness for vaccination went on full swing. Though there were few sporadic episodes of black marketing where medicines were concerned, but there was no untoward incident or rumors regarding the lack of medicine, oxygen, or a bed in the state of Assam. As of now, on October the 4th, 2021, the confirmed cases stand at 6,02,905. Active cases are 4,186. We have reported 5,881 deaths, and the vaccination has taken an upsurge and upstage, and about 70% have got the first doses and 16% have been covered by the second dose of the vaccine. We long to get back to the old state, to the old peacefulness which was present in the state before. And we hope and pray that with help from the private and the government institute and from the measures taken from the union government, we will be able to overcome this menace created by coronavirus. Thank you.
Thank you, ma'am, for such a wonderful talk. Now I would request Dr. Arpita Saxena to introduce our next speaker. I would request Dr. Arpita Saxena to introduce our next speaker.
Good afternoon, everyone. I'm Dr. Arpita. So our next esteemed speaker is Dr. Brajan Lakher. He is a senior consultant in internal medicine and critical care, Health City Hospital, Guwahati. And a special mention is needed regarding that he is a life member of ISCCM, European Society of Intensive Care Medicine, and Society of Emergency Medicine in India. He has been a chairman of ISCCM in 2017 and 19, founder, executive member of ISCCM Guwahati City Branch, founder, secretary, Society of Emergency Medicine in India in the Northeast chapter. He will be speaking on need for blood and component transfusion during COVID. Dr. Brajan Lakher, please.
Good evening, everybody. My talk will be on need for blood and component transfusion during COVID-19. COVID-19 pandemic is severely challenging the healthcare system all over the world, and mortality rate is particularly high in patients admitted to the intensive care unit and elderly age group, as we know. And patients admitted to ICU, they have got higher need for blood transfusion. And this pandemic had a significant impact on blood donation and blood transfusion practices. So my first point of discussion will be how the COVID-19 pandemic has an impact on the blood transfusion practices. If you see this, all the reduced blood donation is a significant aspect of blood banking, because if you see over the weeks of pandemic running from March to April in Italy, this experience is from Italy, where the number of transfusion, blood component and donation also came down. The need for blood also came down. As compared to 2019 and 2020, over March and April, the number of transfusion went down and the donation is significantly, drastically dropped down, causing definitely a difficult situation for blood banking system. But if you see the utilization in the hospitalized patient, because the donation is less, the utilization is also been less, and this the blood conservation strategy was taken. And just before the onset, where COVID-19 wards were open and the elective surgeries were postponed, and the number of transfusion services came down very, very well, along with the donations also. But the cryoprecipitate and plasma use almost remained same. But after some weeks, actually, the transfusion also gradually came up because of the COVID patients. Actually, most of the COVID patients, they had other comorbidities also. Similar things from Madrid, where the number of cases every week went up, the blood component uses in the hospital also came down significantly. And the surgery need for blood transfusion during surgery came down to almost half because of cancellation of the postponed. They postponed most of the routine surgeries, and the ICU need of blood has definitely increased. That was compensated by the COVID ward, where the patients were admitted and the need for blood transfusions were higher. These two actually mitigated the need for the need for transfusion remains similar. Next point of discussion: indication of blood transfusion of COVID-19. The study looked into this. Actually, the large hematoma, where 27% of the cases they had large hematoma, hemorrhage, and anemia of critical illness are the main issues where blood transfusions were considered or given in COVID patients. And the hematomas were mostly retroperitoneal and femoral, cerebral, are mostly related to heparin related heparin injections, heparin or low molecular heparin related. Hemorrhages, the GI and pulmonary surgery related, epistaxis and other anaphylactic locations are also high. Anemia of chronic illness, which remain almost same. That's why these three are the main indications besides ECMO-related blood transfusion, which is also the need for blood is anticipated. Bleeding risk is higher, and these are the most indications in where blood is needed in COVID patients. The risk of bleeding, if you come to the point of risk of bleeding, is less in COVID because we know the major clinical finding in COVID-19 is thrombosis, whereas the major finding in acute decompensated DIC is bleeding. Why? Because there is high fibrinogen and factor VIII activity, and in decompensated DIC there is low fibrinogen activity. So we cannot label it as a when the bleeding happens in COVID patients, the DIC definitely may happen, but we cannot label it as a decompensated DIC. 31% of incidence increase in the incidence of thrombotic complications in ICU patients with COVID-19, and none had actually overt DIC. So bleeding is much less common than thrombosis in COVID-19, but still it can happen in the following situations where anticoagulation related following ischemic stroke or head trauma where we use DPT prophylaxis, maybe COVID may, even in COVID also, the bleeding risk will be slightly higher. Someone who is on ECMO, we know that the blood transfusion requirement may be high. Heparin-induced thrombocytopenia leading to bleed also may be one of the factors where their bleeding may be severe. ITP, interestingly, the SARS-CoV-2 may act like an initial trigger for ITP, and they may unmask ITP, and bleeding rate is usually higher in those cases, almost 61.4% cases. But interestingly, they respond very well to IVIG and methylprednisolone, and the bleeding resolves very fast. How do we monitor actually they both way like thrombosis and bleeding or hemorrhage? We can monitor PT, APTT, platelet count, fibrinogen D-dimer. This fibrinogen D-dimer may be higher in these situations, and platelet count may be still normal or increased as compared to others. We can use TAG where probably as a point of care, and the reaction time is shortened consistent with increased early thrombin burst in 50% of the patient. In COVID clot formation time, K time shortened consistent with the increased fibrin regeneration. Maximum amplitude is increased considering the greater clot strength, and clot lysis in 30 minutes also is reduced, is indicating reduced fibrinolysis. These are the hallmarks of the COVID bleeding, hemostasis. And if you get a picture like this, probably we decide where the we need to give component therapy or maybe blood therapy, component of blood therapy. Is there any relation between blood transfusion and mortality in COVID-19? That is a question we asked, and this paper looked into that. Actually, they have followed up almost 80 plus patients where the transfusions were given, and all patients, the risk actually are related to age, ICU access, CKD, and number of transfused units. And if we segregate the patients as patients admitted to ICU, then age and number of transfused RBC units are significantly carries higher risk of death. And in ward, definitely age, as usual, along with CKD, chronic kidney disease, actually is a high risk for death, dying if someone is needing. Then, with each unit of RBC transfused in ICU patients, the mortality increases by 37. Mortality is almost 1.37. Many a time the blood component therapy, the plasma therapy in COVID-19 actually is the main one of the region where transfusion actually in COVID patients were slightly higher. When making a risk benefit decision, one should this statement, position statement, interim recommendations by American Association of Blood Bank. They say that okay, the risk of CCP compared to standard CVS plasma. CCP is optimally effective when transfused as close to symptom onset as possible. CCP is unlikely to provide benefit to patients with late-stage disease, Again, one in single titer, high titer, a high good antibody quantity in a single high titer unit is sufficient. No need to give a second unit. But this question, need for convalescence plasma therapy has been questioned now. Maintaining a safe and adequate blood supply. The WHO has said that COVID-19 convalescent plasma as an experimental therapy that is appropriate for evaluation in clinical studies only. But the positions paper on COVID-19 from Italy said that CCP treatment is ineffective in hospitalized patients and should no longer be administered. Likewise, in this is again recently published, they said they followed up almost, they compared in the RCT where they have compared with the placebo. There is no benefit. There is no benefit. And in fact, mortality is higher. The 5% died as compared to 1% in convalescent group, CPT, plasma therapy group. Risk of transfusions are just like transfusion of any component transfusion, TRALI, TACO, acute hemolytic transfusion reaction, anaphylactic reactions, then febrile non-hemolytic transfusion reactions, and HLA immunization. These are all known complications of transfusion. But sepsis is also one. And many times people used to discuss that whether the risk of SARS CoV-2 on blood, if blood, through blood, whether the COVID-19 may be transmitted to another persons, and which has been again WHO in the statement say that there is the highly unlikely, it is not has been reported, and this is highly unlikely state. In conclusion, blood transfusion practices are challenged in the COVID-19 pandemic due to low donor numbers, though the demand for transfusion also decreased due to reduced routine surgeries. Although thrombotic episodes are common in COVID-19, bleeding episodes are also reported in specific situations. Need for blood transfusion in ICU patients with COVID-19 is much higher than ward patients. And with each unit of blood transfusion in ICU patients, mortality increases significantly. Role of COVID-19 convalescent plasma therapy is questionable and is not recommended. Thank you for patient hearing.
I would like to thank all the speakers for such a wonderful session. Now I would like Dr. Rabe to take over from here for the next session.
Thank you, Dr. Utkarsh. Taking this enlightening session forward, we begin with the thematic session 2 of the day. The chairpersons for this session are Dr. Soumya Shankar Nath, Professor of Anesthesiology and Critical Care Medicine, Dr. Ram Manohar Lohia, Institute of Medical Sciences, Lucknow. Dr. Soren Panja, Head and Senior Consultant, Department of Internal Medicine and Critical Care, NHRN Tagore Hospital, Kolkata. Dr. Brajan Lakher, Senior Consultant, Internal Medicine and Critical Care, Health City Hospital, Guwahati. Dr. Tarun Singhal, Senior Consultant, Physician, Rashmi Medicare Center, Agra. Now, I would request Dr. Soumya to introduce our first speaker for this session.
Good afternoon. Am I audible? Hello. Good afternoon, everybody. Hello. Let me introduce Dr. Arusi Guel. She's from Oak Hill Hospital, Florida, and consultant internal medicine. And now I request Dr. Arusi Guel to start her deliberation on the dealers of COVID continues in USA, the Delta variant experience. Over to Dr. Arushi Goel, please.
Hello, everyone. I am Arushi Goel. I'm an American board certified internal medicine physician, and I'm currently practicing as a hospitalist physician in a community hospital in Wisconsin. The bed capacity at my hospital is about 200 beds. Thank you so much for inviting me here to talk. I will be shedding some light on the significant surge of COVID-19 cases in the United States in the last few months, which has been attributed to the Delta variant. The evidence of this Delta variant transmitting more readily is unquestionable. But what is unclear until now is if it makes people less seriously ill. We are seeing a significant surge in the number of COVID-19 cases with increased number of hospitalizations in the last 3 months, which is the months of August, September, and October 2021. I will be talking a little bit about the nationwide data in the United States and then specifically regarding cases in Wisconsin, which is where my scope of practice is. Another thing I would like to talk about is why are we seeing this surge? We definitely, like I said before, know that the Delta variant is much, much more transmissible and contagious. And that is likely because of its capacity to bind to the receptors in our nares and spread. The other big reason we are seeing this is because the virus is circulating through the community because of lower vaccination rates, which leads to asymptomatic carriers, which are circulating this virus and spreading it to more number of people. And as long as we give this virus the opportunity to circulate and spread, it will keep on mutating and forming more and more variants and mutants, which will lead to this vicious cycle ongoing. So the only way to stop and break this cycle is immunity in the community, which can be through the vaccination. Just shedding some light on the vaccination rates in America as of now, today, per CDC data, 56.7% of the nation has been vaccinated. So we still have 44% of the country which is not vaccinated. So we have a long way to go, and I think encouraging everyone to get vaccinated is the way to go. In the last 3 months, the United States saw a significant surge in the number of COVID-19 cases. Going over some numbers, in some of the states which were massively hit, Texas saw all of their ICU beds being full. In the month of August and September, more than 10,000 Texans were hospitalized with the virus. Florida saw another great peak as well, with more than 15,000 people hospitalized in the ICU with COVID-19 infection. Southern states, including Louisiana, Alabama, were pushed to the brink with up to their capacity with COVID-19 admissions. Some states saw surges worse than the first surge in March of 2020. In this major surge, there was a major and unpredicted increase in the COVID-19 admissions and hospitalizations, which we did not see coming since we did have the vaccine and we were more versed with the variant and the virus being around for an year. Another contributor to this surge could be fall and then the schools reopening, because we are also seeing the Delta variant being rapidly spread in the younger children. And from them, it is spreading to the adults who are vaccinated and non-vaccinated. And we are seeing more unvaccinated people getting more sicker and being admitted to the hospitals. As of October 13th, a total of 44,615 528 COVID-19 cases have been reported. As of October 14th, 405.4 million vaccine doses have been administered in the country. Now I'm going to talk a little bit about my personal experience practicing in Wisconsin. Like I said, I practice in a 200-bed community hospital, and I'm a hospitalist, so we primarily take care of all the COVID-19 admissions and hospitalizations. In my hospital, until the month of June and July, we were doing exceedingly well with 0 hospital admissions with COVID. We had closed down our COVID-19 unit. We thought this is over, we are done with it. And then we started seeing a surge towards the end of July 2021. I'm going to say the numbers in the sum of 7-day average. So in the last week of July, the 7-day average of admitted COVID-19 patients in my hospital went up to 4.4 from 0 in April, May, and June. On August 27th, it went up from 4.4 to 21.6 7-day average admitted of COVID-19 patients. By 24th September, we hit up to 27.7, and by October 1st, the 7-day average of admitted COVID-19 patients went up to 31. Now I'm going to talk a little bit about the admissions. So the 7-day sum of COVID-19 admissions went from 0 in July 2021 to 14 by August 6th. And then a massive increase to up to 40 on September 24th. And then towards the 1st of towards the 1st of October, up to 31. Our ER visits massively increased as well. A 7-day sum of ER visits around July 9 was 0. By July 30th, it went up from 0 to 42. By August 27th, it went up to 56. And by October 9th, it went up to 79. So this was a massive increase, you can say, from 30th July to 9th October, from 0 to 79 ER visits. This is a 7-day sum again. So this kind of shows the significant and massive increase we saw. I can say we were not expecting it, but we were definitely better prepared since we had dealt with the virus for an year. We opened our COVID-19 unit back, and we dedicated staff that would be taking care of only the COVID-19 patients. Talking about this, I would like to touch a little bit on the COVID-19 protocol we are following at our facility. So the first line of treatment that we have been using has been the steroids, dexamethasone, which is we are using for anyone who is hypoxic, meaning less than 90 to 92% oxygen saturation on room air. And the second line of treatment is the antiviral medication remdesivir, also for hypoxic patients who do not have contraindications to use and are able to tolerate the course. The newest addition to the treatment that I wish to speak about is the baricitinib, which is a Janus kinase inhibitor. This medication was earlier approved for use in rheumatoid arthritis. There was a randomized trial with about 1,500 patients which showed that the use of baricitinib in patients who are not on mechanical ventilation, that is patients who are requiring high flow nasal cannula or who are on nasal cannula and are having rapidly increasing oxygen needs, the addition of this medication led to reduction in 28-day mortality. The benefits have been maximized with the use within 96 hours of hospital admission. I myself have treated patients over the last 2 months with the medication, and I have seen good response. I haven't had any patient develop any side effects or anaphylactic reactions from the medication use. So this is the newer medication we are using. So these are the 3 modalities of treatment we are going on with. And then there is anticoagulation, which has been seen as to have significant benefits, and we have been using it from the time of COVID infection that when it started. To kind of conclude my talk, I would again like to emphasize that the only way to spread stop the spread of this virus and cut back on this surge and eventually get back to normal is vaccination. And I strongly urge everyone who's listening to me today to get vaccinated. I would like to add there that you can still contact the virus if you're vaccinated, but your chances of getting sicker and hospitalized are much lower.
Thank you, ma'am, for your valuable input. Now I request Dr. Brajan to kindly introduce our next speaker.
Dr. Raymond Dominic Savio. He's the lead consultant critical care services Apollo Proton Cancer Center, Chennai. And his special mention is his immediate past chairman of ISCCM Chennai branch, is the National Executive Committee member ISCCM, Guideline Committee member ISCCM, reviewer of Indian Journal of Critical Care Medicine, ISCCM, and accredited teacher and examiner. He will be speaking on post-COVID limb ischemia. I invite Dr. Savio to start his deliberation, please. Over to Dr. Savio, please.
A very good day to everyone, and hearty congratulations to the organizing team for putting up this beautiful show. I'm sure we all have been through varied experiences during this COVID pandemic, and one such experience is what we're going to be talking about right now, the post-COVID acute limb ischemia arising out of arterial thrombosis or thromboembolism. We're not going to be touching upon venous insufficiency. Now, this session is slightly to be on the lighter side because, one, it is a relative rarity. In the whole of 2 years, the last 2 years, we've had less than 100 reports in literature. Well, I do understand that the real world experience may be a lot more, but then yes, the denominator is also enormously huge. And the other thing is probably that we have more number of uncertainties than any kind of credible data or valid guideline that I can present to you for management or for identification or for anything to do with this post-COVID acute limb ischemia. So we know that the COVID virus is very notorious, unlike its colleagues, the MERS-CoV, SARS-CoV, or for that matter, the influenza, which have all been variably associated with venous thromboembolic disorders. We have seen and we have ample evidence that COVID-19 is associated with a high risk for arterial thrombotic events as well. Even though we do not know the exact pathophysiological mechanism, we strongly believe that endothelial dysfunction is at the heart of the matter, because we know that the coronavirus invades the endothelium through the ACE receptors and then starts a process of endotheliitis, a cascade of hyperinflammation, and then this goes on to become a vicious process. Now, all this, along with parallel mechanisms such as the prevailing hypercoagulable state, we know that most of our patients come with very high D-dimer values, very high fibrinogen levels, all of these. And then there is this cytokine storm, notably high levels of interleukin-6 and interleukin-1, all of which trigger or propagate this endotheliitis. And, ultimately result in a very highly hypercoagulable or a procoagulant milieu. Not just this, it has also been shown that hypoxia itself can change the phenotype of an endothelium. Now, the normal phenotype of an endothelium is something that has resistance to thrombosis. Now, this gets converted in the presence of hypoxia to a prothrombotic endothelium. And all of this ultimately result in thrombotic manifestations, venous, arterial, and then this arterial manifestations can be virtually in any organ. Commonly reported have been coronary, cerebrovascular accidents, even mesenteric ischemias, and of course, acute limb ischemias. And it seems like, because all these processes happen more often during the acute phase, that whether acute limb ischemias are also more common only during the acute during the acute phase, not really, because we have had reports of patients presenting with arterial thrombotic disease way beyond their period of recovery. This only means to say that the endothelial dysfunction is global and persists and probably propagates. For how long, we really do not know. Probably the first report of arterial thrombotic events came up somewhere in mid-spring 2020. It was in this analysis by Klock et al. From his Dutch ICU, where he analyzed 184 patients with COVID, where he gave a cumulative incidence of 31%. That is for all the thrombotic and thromboembolic venous and arterial disorders. And in his cohort, there were 3 patients who presented with arterial thrombotic events, all of which were ischemic strokes. Now, the interesting point here was that all of these people were on thromboprophylaxis. So this study, number one, showed that arterial thrombotic problems can happen in COVID, and number 2, raised the question whether thromboprophylaxis dose was enough, or whether all of these patients should already been on therapeutic anticoagulation. So soon following this, there were several case reports, series, prospective reports, retrospective reports, and then we started generating our literature. Now, this is one of the relatively larger series with close to 20 patients with COVID and acute limb ischemias from a vascular surgical unit. So they go on to say that the incidence of acute limb ischemia went up by at least 9 times or 10 times compared to the pre-COVID period. You can see there, Jan to March in 2019, the incidence of ALI was something like 1.8 versus 16.3 in 2020. So that's a 9 times heap. Okay, so they had a total of 23 patients presenting with ALI, of which 20 were COVID pneumonia with acute limb ischemias. 19 or 18 of them were men. So there was a male preponderance. And of course, they had more number of lower limb ischemias than upper limb ischemias. And something very important that came up in this particular cohort was that they had very low rates of successful revascularization in comparison to their own benchmark. Okay, so they defined unsuccessful revascularization as death or amputation within 24 hours, or the need for a revascularization procedure, a repeat revascularization or reocclusion within 30 days from the first procedure. Also, they highlighted the fact that patients who received prolonged systemic heparin, that is systemic heparin infusion, post-revascularization actually had better survival, giving all due respect to the limitations of a small cohort. But this study or this cohort did bring up certain valid points. And then come up these small cohorts and case series, which only proved a particular point. That is, the only thing predictable about the presentation of acute limb ischemia from thrombotic, arterial thrombotic events is that they are totally unpredictable. In the sense, ALIs had no relation to neither the disease severity nor the viral load, nor was there anything particular about the timing. Look at this particular cohort from New York City. They say that the incidence of acute limb ischemias, so this is of the thrombotic episodes, is something like 13% in ICU, the severe COVIDs, whereas in this other paper, we see that the incidence could be as high as 38.1 patients in just mild COVID. And then it also is very clear that majority of them have actually been on thromboprophylaxis. Okay. Likewise, even when it comes to timing of the disease, it is not necessary that all of these events happen during the acute phase. Up to a third in this particular cohort of patients presenting with ischemic limbs actually did present beyond 40 days from time from recovery. Just again, reiterating the fact that this endothelial dysfunction is probably global, prolonged, and maybe self-perpetuating. Okay, so timing is extremely difficult to ascertain, and maybe by and large, a lot of these patients present during the second week of illness. A few other points worth mentioning, like I already mentioned, there is a male preponderance to the extent of 70 to 80% of those presenting with acute limb ischemias being men, and invariably most of them had associated cardiovascular risk factors. Many of them were above 60 years of age. Lower limbs were more often the ones that is affected, to the tune of 60%, with upper limb ischemias presenting in 30 to 40% of the times. Again, Popliteal arterial occlusions were noted more commonly than the femoral, followed by iliac. If it was the upper limb, maybe brachial and radial. Both of these were seen with fairly equal numbers. Majority of the patients presenting with acute ischemias presented in Rutherford 2A or 2B, which means they were all having threatened limbs requiring intervention. Okay, and they were potentially salvageable. High rates of post-revascularization occlusions have been reported in most of the trial series, and likewise heightened mortality as well. Higher chances of somebody undergoing amputation within 24 hours from revascularization has also been noted. Similarly, like was already discussed, the role of post-revascularization infusion of heparin was shown to improve survival and the post-vascularization success in many of these small cohorts, also raising the hypothesis of this antagonism with the COVID virus and heparin. Some of these instances have also been linked to the diagnosis of vasculitis syndromes, like the presence of anticardiolipin antibody or anti-beta-2 glycoprotein 1. But again, these are more often reported with venous events. So during this particular second wave of the COVID pandemic, we in our institute witnessed 4 arterial events. I would not say all of them were acute because they had varied timing of onset from the actual disease. So this was one particular individual, a 50-year-old male who presents with recently treated severe COVID elsewhere. You can see, let me just pause the video for a while. So he basically had syncope at this other hospital on day 16. He was referred here. We found out that he had a watershed CVA. And at the same time, he also had a threatened right upper limb. Doppler assessment revealed the block to be somewhere in the right brachial area because there was axillary flow that was preserved. He had acute kidney injury, profound hemodynamic instability, so we couldn't move him for any of the imaging studies. He was taken up for urgent surgical revascularization. What you see here is an open exposure of the brachial artery with delivery of the clot. This is the clot. Okay, so the clot, quite a significant length of the clot is being delivered. Post revascularization, we had him on heparin infusion, and this was a successful revascularization. He tested negative for vasculitis syndromes. Okay, and moving on to the next one, very young individual, 30-year-old male with mild COVID. He had an underlying CA colon as well. And somewhere around the 6th week of his illness, he had to undergo this surgery, during which time he had an A-line which was promptly removed. He had a A-line thrombosis associated digital ischemia. He was initiated on heparin infusion, but on account of GI bleed that had to be stopped, but then he recovered spontaneously. This is another patient presenting with desert foot, basically complete lack of circulation in the distal leg, amounting to an amputation. He presented with a Rutherford 3 class. He also had an eventful post-operative period, but could be salvaged. This is another patient. I'm not sure if I would classify this under any of the major arterial occlusions, but then small vessel vasculitis in somebody who was treated for moderate COVID and mucor, presenting 4 weeks after the onset of COVID with painful lesions. You can see those painful lesions over there. A punch biopsy reveals the vessel, the blood vessel, to be filled with inflammatory infiltrates. There's a whole lot of lymphocytic infiltrates correlating with the typical pathology of COVID. So at the end of it all, we are left with wanting for more answers, like to be able to identify who is at risk. Is just a D dimer or an elevated fibrinogen level enough? Or is there more? Is just a routine thromboprophylaxis enough to protect us from these sort of arterial thrombotic events? We do not know. What sort of anticoagulation therapy should be given for these patients? Heparin, infusion, subcutaneous, any role for the newer agents? Are they superior to lower molecular weight? We have no clue. The role of antiplatelet agents, especially aspirin, largely extrapolated from our intelligence from coronary and cerebral sciences. I'm not sure if it applies for COVID as well. And whether these patients are at any increased long-term risk for further arterial thrombotic episodes in their life. Until we get answers for all of these, we'll have to wait patiently. Thanks for your attention, and I'll be very happy to take questions. Thank you.
Thank you, sir, for such an erudite talk. Now I request Dr. Soumya to introduce our next speaker for the session. I request Dr. Soumya to introduce our next speaker for the session.
Yeah. So good afternoon, friends. I have the opportunity to introduce a very eminent speaker, Dr. Sungun Park. He is Professor of Pulmonary Allergy and Critical Care Medicine, Department of Internal Medicine, College of Medicine, Halim University. Halim University Sacred Heart Hospital. He is also Director of ICUs of Halim University, Halim University Sacred Heart Hospital, Director of the Public Relations Board of the Korean Society of Critical Care Medicine. He was awarded the Resident of the Year in 2003, and he is also the Epidemiology Trainee or Investigator of the Year in 2004 from the Korean Center for Disease Control and Prevention. I welcome Dr. Sungun Park and request him to present his talk. Dr. Park, please.
Hi, this is Sungun Park from Halim University in South Korea. There are several therapeutic options for COVID-19. Today, I'm going to talk about monoclonal antibodies for treating COVID-19. We may say that there are two types of monoclonal antibodies. The first type is drugs which are specific for human proteins, such as GM-CSF or IL-6. Among them, tocilizumab can be the most commonly used drugs for treating COVID-19. The second type is those targeting SARS-CoV-2 virus protein. There are 4 monoclonal antibodies targeting the receptor binding protein of SARS-CoV-2 spike protein. Among the anti-IL-6 receptor blocking antibodies, tocilizumab and sarilumab, which are formerly approved drugs for rheumatoid arthritis, are currently approved and available for treating COVID-19. Although some studies showed no evidence of benefit from tocilizumab, there are 2 largest trials showing beneficial effect. These are recovery and REMAIN-CAP trials. Let me show you the results of REMAIN-CAP trials. They investigated the results in ICU patients who received respiratory or cardiovascular support. As you can see in this left figure, the treatment with tocilizumab or sarilumab improved organ support free days by 10 days, and they also improved survival rate compared to control group. Recovery Collaboration Group also published their results in Lancet. They investigated these results, this data in hospitalized patients with hypoxemia and those with higher level of CRP at baseline. As you can see, the treatment of tocilizumab improved survival rate and also improved the chance of discharge rate. These beneficial effects were also seen among patients receiving steroids. The group also performed meta-analysis, including all 9 ISTs. As you can see in this table, the treatment with tocilizumab decreased the 28-day mortality by about 14 percentage. So IDS guideline recommends that in hospitalized adults with severe or critical COVID-19 who have elevated marker of systemic inflammation, the tocilizumab and plus steroid are recommended rather than steroid alone. When tocilizumab is not available, they suggest the use of serilumab. The WHO also recommends these 2 drugs for treating COVID-19, severe COVID-19. Next, I'm going to talk about monoclonal antibodies targeting the receptor binding domain of SARS-CoV-2 spike protein. As I mentioned before, there are 4 monoclonal antibodies approved for the use for COVID-19. First, I'm going to talk about regdandimab. Regdandimab is the only drug approved in Korea. If you see the first figure, the reduction of viral load doesn't seem to be significantly lowered compared to control groups. However, the treatment with regdandimab decreased the time to clinical recovery and also decreased the rates of hospitalization or oxygen therapy. The beneficial effects were more pronounced in moderate COVID-19 than mild COVID-19. Also more pronounced in patients aged more than 50 years. This is the propensity matched analysis data performed in South Korea. As you can see in the right table, the treatment of regdandimab decreased the disease aggravation rate by about 83%. Next, maybe everyone knows that the President Trump received monoclonal antibody called Regencor, which is a combination of casirivimab and indevimab. The combination treatment with casirivimab and indevimab decreased viral load at day 7 with a great effect in patients with higher viral load at baseline. This is the phase 1-2 study. However, phase 3 study using the combination treatment was also released. Although there was an amendment in the study design during the study period, as you can see, they found the reduced hospitalization or death rates from any cause in both amended cohort and the combined cohort. The combination treatment also reduced the time to resolution of symptoms. Next, I'm going to talk about bemlanivimab. If you see the phase 2 study, they demonstrate that only one of 3 doses showed a reduction in viral load. And if you see the right figures, this TICO trial, they compared the treatment with bemlanivimab plus remdesivir or remdesivir alone. So they found that there was no big difference between the 2 treatment groups. So recently, FDA revoked their EUA for bemlanivimab monotherapy because of their uncertain efficacy and also they are concerning about the reduced sensitivity of variants, SARS-CoV virus variants to bemlanivimab monotherapy. However, after then, the combination treatment with bemlanivimab plus atezolizumab was also released. As you can see in this table, in this slide, they showed a lower incidence of hospitalization or death rate with the combination treatment. They also showed an accelerated decline in viral load with this combination treatment. The last monoclonal antibody that I want to talk to you is sotrovimab. This is a phase 3 study. If you see the result, interim analysis result, the treatment with sotrovimab decreased the percentage of hospitalization or death for any cause. The size of reduction is about 85%. However, there are some studies reporting concerns about the emergence of SARS-CoV-2 virus mutations. So I think that as the frequency of the use of monoclonal antibodies increases, we need to be cautious for the emergence of these virus mutations. Also, there are some concerns about reduced sensitivity of SARS-CoV-2 variants to this antibody therapy. These results were published in Nature Journal. They compared the four monoclonal antibodies using 3 SARS-CoV-2 variants strains. As you can see, the sky blue one, the beta variants. The beta variants have reduced sensitivity to bemnifosbuvir, etesevimab treatment. Particularly, the red one, the Delta variant, which prevails in South Korea, have reduced sensitivity to bemnifosbuvir. However, as a combination treatment, the combination with casirivimab plus indemivab seem to have better sensitivity compared to the 3 SARS-CoV-2 variants compared to the combination of bemnifosbuvir and etesevimab. So IDSA guideline recommends that ambulatory patients with mild to moderate COVID-19 need to be treated with bemnifosbuvir, etesevimab, or casirivimab plus indemivab or sotrovimab, rather than no neutralizing antibody treatment. However, among hospitalized patients with severe COVID-19, the guideline recommends against bemnifosbuvir monotherapy. In summary, among IL-6 receptor blocking agent, the use of tocilizumab in combination with the steroid is recommended in hospitalized adult patients with severe or critical COVID-19 with a high level of CRP levels. And monoclonal antibodies targeting SARS-CoV-2 virus spike protein, such as regdandimab, bemnifosbuvir plus etesevimab, or casirivimab plus indemivab, or sotrovimab, are currently available and approved for treating mild to moderate COVID-19. However, local availability of the drugs or local variant susceptibility should be considered.
Thank you so much, sir, for such an informative talk. Now I request Dr. Brajan to introduce our last speaker for this thematic session. Now I request Dr. Brajan to introduce our last speaker for this thematic session.
Thank you. Dr. Arvind Dahiya will be the next speaker. He's the Director and Intensive Care Specialist at Kainos Hospital, Rohtak. He has received award for Haryana's Health Minister Anil Viz for the best hospital in Rohtak. And Dr. Dahiya will be speaking on COVID tsunami, balancing resources between COVID and non-COVID care in small town. Over to Dr. Dahiya, please.
Good afternoon, everyone. First of all, thanks all the organizers for giving me the opportunity to express my thoughts on such a fantastic platform and learn from each other. So this talk is about balancing resources between COVID and non-COVID with a small town perspective in a deluge-like situation. I'm sharing my experience of a tertiary care center in the tier 3 small town, Rohtak in India, and focuses on what we learned and what we can learn from the future. It's a 150-bedded service with ECMO, emergency services, and to make the matter worse for us, the 30 specialty in one building plus radiation oncology in the same building where we were admitting COVID patients. This is pretty much story of the old small to medium healthcare facilities in small town. And that's why it became even more imperative to get the balance right in the deluge-like second wave. So here, before I objectives of the talk, here I'm assuming that we provide the best of the best possible care for our COVID patients who work hard. The new paradigm is about providing uninterrupted time-critical surgeries, medical emergencies, neurosurgeries, trauma, all these services during the COVID deluge and preventing the cross-infection in vulnerable non-COVID patients at the same time. And without missing the focus on the outcomes on both the side, not sacrificing one for the another. So constraints and challenges. In small towns, we have to stay with only one small building, not like big towns where we can afford multiple towers. And many times infrastructure is also shared given the financial constraints. Some hospitals might not have a CT scan and their own big lab. And staff is also difficult to find, especially when the big metros are hiring at the same time. Stand no chance. Still, we get the balance right. This is an example of an ECPR which we did during the peak of the COVID wave and did it successfully. To get such a balance right, we need to focus on cross-utilization, protocolization, and the optimization of the resources with out-of-box thinking. All these things cannot be done overnight. It has to be the part of the DNA of your thought process organization. Why is this only COVID? We need to have a contingency plan for all sudden surge of patient, be it natural disaster or an accident. As well as comes the cross-utilization. We focus on the cross-utilization of human resource. In small towns, we don't have a luxury of multiple doctors in one specialty. So we need to have one hospital, one goal. For that, we implemented cross-training for all the doctors. So pediatric patient doctors can handle adult emergencies and vice versa. We trained our nurses, OT staff in the same way as they can be doubled up for nurses. We keep sending, we do send our ward nurses to ICU and ICU nurses to ward so that when time arises, we need to use them anywhere we need to use them. And we have a policy for mass casualties from day one that we need to have to handle such a deluge and get the balance right. All this can only be done when we have a support from the infrastructure, for example, oxygen plant. We had the oxygen plants 2 years before the COVID, and that's why we were able to maintain both COVID and non-COVID ICU without interruption. 40 to 50% of our oxygen came from our own plant, rest we got from the government, and that's why we kept going. 80% of our hospital bed can be converted to HDU any given of. And we have 2 entries and the building is designed such a way it can be separated in 2 buildings without interfering the work with another. So that's why we prepared 3 extra ICUs in no time, and we were ready on April 10, 2020. So lesson from here is that for new buildings, you need to focus on the design with these things in mind. Now come the resource optimization part of it. We have a logistic team 24/7, which is dedicated, and doctors are need not to worry about the logistic, oxygen, drugs and all. They look after that part. In small towns, we know there are constraints. Small hospital cannot afford all these things, but they can share the resources. For example, oxygen plant. Few hospitals can jointly put one and share the resource. Same way they can put the dedicated team which can support 2 or 3 hospitals, and that way they can focus mainly on the patient care. Any number of hospitals can come together depending on what they need in this crisis time. This kind of a support from logistic team, we were able to ramp up our facility in no time and increase from bed from 30 to 16 ICU. All this was extremely well supported by our staff, where we focus on the training, building their confidence, and providing them support. For example, before putting patient staff into COVID area, we did antibody testing. That gave them a huge confidence. When they were not well, we have a dedicated team to look after our staff. We need to look after our staff as well to gain their confidence and win their heart, so that they can put their mind and heart into the care of the patient. Again, if 2 or 3 hospitals come together, then even small hospital can provide such a service for their staff and look after them well. Never ever underestimate the power of drills and the protocols. I'm showing a little video of our COVID ICU, which is mainly run by nurses. We have 6-7 ICUs running at the same time during COVID. 46 beds were given to COVID ICUs and 12 to 13 beds given to the non-COVID ICUs. The 20 ventilators running all the time. All this proning, weaning, feeding decisions, they were taken by nurses with our supervision. So practically, COVID ICU were run by highly protocolized, highly trained nurses. And that's why we were able to balance the services on both the sides. All this pruning was done without medical assistance most of the time. For example, this guy is 180 kilo, prone 10 to 12 times, all by nurses. I'm cutting short the video because of time constraint. So all this also need a bit of out-of-box thinking. Before I move forward, let me reiterate 3 points we have discussed: optimization, cross-training, and supporting your staff. Now coming to the new ideas, out-of-box ideas. For example, home care with telemetry. Home care, we all know that base is the key element of COVID care, but we added on top of it telemetry concept. Telemetry is basically putting wearable sensor on the patient and then monitoring the data from the home, and all the data being beamed to us 24/7. So patient had the confidence that someone is looking after them from a distance, that they are watched. That way, in the situation when we didn't have a bed, we converted people bedroom into HDUs, giving them oxygen, concentrated oxygen. With this monitor, they were practically in a HDU. And whenever situation got a bit more critical, we got them into the hospital. This is how we monitor. This TV screen was in our ICU room. We monitored our telemetry patient 24/7. Next concept introduced for the field hospital. We learned it from the army. These waterproof tents with air conditioning and oxygen cylinders and concentrators functioned 24 all through the second wave, first wave as well. They stood the rain, wind, everything, and they have become our actually HDU, 12-bedded HDU in the parking. We provided daycare here. They become our COVID emergencies, holding bed till they get a bed in ICU. And that way we were able to separate our COVID from the non-COVID ICU. And we gave assured confidence they will be safe when they come to our hospital and get a non-COVID care. If you don't assure your patient well, they won't come. There's no point in having a balance if the patients are not feeling confident to come to a facility. So just a glimpse how these intense field hospital saved so many lives in deluge. We staffed them till midnight. But during all these good things, we also have ethical challenges. ICU care for elderly in pandemic was critical to balance the services. I mean, it was very difficult to put a line, but we kind of put a line. The more than 70-year needing ventilation will not come to ICU at all. At the same time, then we got a question of 73-year fit and healthy versus 45-year-old CKD on dialysis. Which one you choose? It's a very difficult question. Age is just a number for many people. They're fit, and for many people who are young, but they have comorbidities. So practically, we focus on 2 things. Number 1, quality of life and survivability. Right or wrong, we don't know. I'm not sure we got it right or wrong, but we tried with a clean heart, and we tried our best, whatever we could in those times. One more big challenge for us was oxygen shortage. Should we stop admission to safeguard or keep taking? I don't know. What was the right thing? But at one point, when we had only 4-hour oxygen, we stopped all new admission for 72 hours and started taking when we eased out a bit, because we wanted to safeguard our patient admitted first before taking new patients. And that will optimize the care for both the sides. During that mucormycosis crisis, we have a limited supply of amphotericin, where we knew we need amphotericin for most of the people. But then I called all the relatives who needed amphotericin B, had a discussion with them that, look, we have limited number of injections, only some will get in the amphotericin, some will get tablets. So people agreed to that, and we decided during the high sickness who will get ampho and who will get the tablet. This was very difficult decisions. We don't know what we did, but we did again whatever was available at the time to us. Staff exhaustion was a real problem. Many nurses worked without a break for 45 days. Many doctors worked without a break for 40 days. Potentially preventable death could have increased because the overstretch system. Should we shut down the beds when the staff was extremely tired? We don't know. But again, we tried to stop the admissions when we realized that the staff was overstretched, because that would endanger our admitted patients. In that situation, we focus first on our patients who are admitted. Many times we stopped admission for 8 to 12 hours just to give a breather to our staff so that they can focus on the patient who are admitted, stabilize them, have a bit of a break, and then start admitting the new patients. So that brings to me now, final few slides of our talk. Don't wait for the crisis. You need to start now and prepare for the future pandemic if it comes. And in that one, crisis management should be a part of the design and development of the hospital. Cross-utilization is key. In small towns especially, support each other, help each other, and share your resources is the critical for maintaining the services. Thank you. This is a photo of our COVID survivor. It was an ECMO. Thank you very much.
Thank you, Dr. Kumar.
Thank you, sir, for such an enlightening talk. With this, we have come to the end of our session and day 2 of our World Conference on COVID and Critical Care. Thank you all for your contribution in making this event a great success. We are looking forward to see you tomorrow. Have a great day, everyone.